See the sign-in process. Please make sure you sign in if you wish to receive any credit. The accreditation policy is listed here. You can read that as well. These are my disclosures. I do some consulting with Gilead and Vive, and I work for a company that does database analysis called Trio Health. You'll also get an initial evaluation, electronic evaluation, within the next couple of days. Please fill that out and let us know what you think of the presentations, and then I'll help guide future presentations, as well as get you CME credit if that's what you wish. The learning objectives are: 1, to discuss the use of PrEP as a component for prevention, to describe lessons learned from real-world use of PrEP to lower community rates of HIV transmission, and to identify strategies to provide PrEP for people at risk. Let's look at some of the epidemiology. We know that when we look at the lifetime risk of diagnosis of HIV infection in the United States, and clearly this would be different in Kenya, that you see that there are significant differences by race, Black and Hispanic being a significantly different race than the white population, and there are differences in risk between males and female. Furthermore, when you look at risks among MSM population in those groups, you see a significant difference in the Black, but not so much in the white and Hispanic groups. This calls for what we call a status-neutral HIV prevention care, which is that we don't make distinctions between treatment and prevention. That essentially, anybody who's at risk comes into our healthcare system looking for prevention. We try and do STD and HIV and prevent both commonly occurring infections in any part of the body, be that sexually transmission or other. Then once we're doing that prevention, sometimes that leads into treatment. And so we don't look at a distinction between prevention and treatment programs. It's more looked to be the same sort of treatment for both. When we look at different coverage amongst the states, it's very clear that jurisdictions, places where there are higher levels of PrEP coverage, had significantly larger declines in new HIV diagnoses. So we know that when it's provided, it's working. There's a dose-response relationship existing between PrEP coverage and the magnitude of these declines. Now, what are the areas for barriers and potential solutions? There's limited awareness, both education between patient and provider, communication between providers, low risk perception. This is a common issue that's relevant to both providers and patients. Patients underestimate their risks. Women especially. They might have relations with one man, but that one man has relationships with multiple women. So to that woman, she's not at great risk, but in fact, epidemiologically, she is. Providers also underestimate risk, and this is an important thing. And part of the reason that they do that is because of stigma and improving understanding and how we can talk to patients about their sexual risk. There are issues also listed in this slide of limited access to medical care, concern about the side effects, and these are predominant barriers for why people don't access PrEP readily. There are the two key tools, though, for HIV prevention are going to be getting people tested and providing PrEP and providing sexual history for them as well. All people who desire PrEP, people who come in and ask about that, if possible, should be offered PrEP. I'm not sure that's possible yet in Uganda, but it's an important principle if it could be achieved. We know that oral PrEP can be offered in either FTC TDF, FTC TAP, which I don't think is available in Uganda, and the use of cabotegravir, injectable every 2 months. Let's look at PrEP and STIs. The first piece is that it's critically important, if we're going to identify people who are interested in PrEP, to be doing sexual histories. That HIV acquisition risk among patients without HIV, we see that partners are virtually unsuppressed, indications, high prevalence communities, and the general populations. So the idea is to focus our observation and sensitivity to who is at risk, with people being with partners being the first group, and then people being with sexual exposures or sexual testing being the next higher group. We know that the definition in the United States for who comprises this group of risk is anyone who has had anal or vaginal sex in the past 6 months with a sexually active partner with HIV, had a bacterial STI in the past 6 months, or didn't use a condom. So essentially, if you've had unprotected sex without condom in the last 6 months, you're considered at risk. HIV testing. The testing algorithm, and this is assuming that there's been no recent antiretroviral retroviral prophylaxis use. We go ahead and get everybody tested. A rapid test, if it's positive, you know what to do with that. If, on the other hand, it's negative, it's possible that if people have had significant exposures, you might want to get a viral load testing, quantitative or qualitative HIV RNA assay. That would be safe for people who have exposure as well as symptoms. Once you get that test, you can send that off for quantitative or qualitative RNA, but that's specific to individual patients, and you would decide that at the time. If, on the other hand, there was testing and there was recent or ongoing use of prophylaxis, then you'd have to do both an antibody antigen test and potentially as well an HIV RNA test. And you can see here that if the antibody antigen test is positive and there's no viral load detection, you have to repeat the test to see if there's true viral load. If, on the other hand, the flip is true, that there's a negative antigen antibody test and a positive RNA, again, you have to repeat the test. For the people who are positive for an antigen antibody test with total positivity on RNA, that's easy, as well as it's easy for the group that's negative on both. So this is the delineation. If the two tests are discordant, you have to get a follow-up RNA qualitative or quantitative test. Now let's say you get ambiguous test results. What do? The first thing is to assess medication adherence, to retest with a new sample, antibody antigen or quantitative test. And then often you can talk about other things to do about figuring out what the patient's doing. If patients are on oral PrEP, you can continue PrEP, and if you think they've been exposed, you have to add a third drug to complete the regimen and discontinue PrEP during that time. If, on the other hand, they're on cabotegravir and you think that a patient could potentially be positive, do not administer any new. If you believe that indeed the patient is positive, start ART immediately. Check for integrase resistance. And if there's a low suspicion, just stop the cabotegravir and get testing. The identification of viral replication can be tricky when a patient is on cabotegravir because it can suppress viral replication and delay antigen and antibody protection. It's necessary to use both rapid tests and antigen antibody assays, which can be delayed, but also RNA levels can remain low or undetectable. There may be such low levels that these tests are flickering and unclear what the result is. It can be a tricky situation. In HPTN 084, you can see here that among rapid tests, only in the oral regimens were 2 rapid tests that were both reactive, 100% predictive, and that without that, a single test was not nearly good enough. So HIV antigen antibody tests could be frequently positive, and it required 2 rapid tests in order to know that indeed someone was positive. And so this is very important for both oral regimens to know that you need 2 tests. And for cabotegravir, it's unclear, and so additional testing is probably necessary. In a follow-up study to HPTN 083, where they looked at what the positive predictive value was of a single positive HIV RNA with patients on long-acting cabotegravir, you could see that out of 27 patients, 22 were adjudicated as false and only 5 as true positive. So the positive predictive value was under 20%. And those were the people who had cabotegravir, about 9% of them in the last 6 months. So the conclusion is that a single isolated HIV RNA performed poorly for detecting HIV infection in the last 6 months. And even with qualitative and quantitative viral load RNA testing in patients on cabotegravir, you need 2 tests, not just 1. With oral, you can get away with 2 tests for antigen and antibody. With cabotegravir, with injectable, you need 2 viral load tests, RNA tests, to prove true positivity. There is a syndrome called Levi, looking at what happens when people get infected on this, and there were 6 incident infections that occurred despite on-time cabotegravir injection. So a very high rate of success, but still these people who were able to convert during this period, and these occurred within less than 6 months after the last 6 months. And you can see here that this duration, they could have had acute HIV, it could have waxed and waned transmission would be unlikely. It's a vague situation because of low viral load levels. So in these patients that start to get symptomatic, you need to be consistently checking for viral load measures, and if necessary, you can hold off on cabotegravir while you're looking at that, and then you have to make the decision if you want to be treating. But in light of the fact that you might not have clear serologic testing, that can be difficult to do. I'm going to move now on into the use of doxycycline for STI post-exposure prophylaxis in MSM. And this is a study that showed that chlamydia, gonorrhea, and syphilis rates in MSM without HIV are at increased risk for STI, and that when you use doxycycline versus no doxycycline, there was a significant reduction of the first STI. Significant reduction both for syphilis and chlamydia, no true reduction for gonorrhea. When another study that looked at this, the DoxyPEP study, which looked at MSM in transgender women. So you give 200 milligrams taken as PEP within 72 hours after condomless contact. And what they showed is that for the people on PrEP, there was a significant risk reduction of 66%, and for people with HIV, a significant reduction of 66%. However, this data, when you looked at this, again here, going across gonorrhea, chlamydia, and syphilis, you see reductions in all the groups. However, there is also colonization that can occur. There's a concern about risk of resistance for this. And you can see here that DoxyPEP may be less protective against doxycycline-resistant strains. And so only time will tell if we're going to see a greater incidence of resistance in these settings.
No volume. Oh, if you want. I don't.
This slide summarizes the PrEP options. We know that for MSM and transgender women, and heterosexual men and heterosexual women, there are different drugs that are approved by the FDA. Oral FTC, TDF, is approved daily for all. For on-demand, meaning when patients say they have an exposure in the last 24 hours, it's off-label for both men and women, and there's more data on that for men than compared to women. Oral FTC TAF is not approved for heterosexual women or transgender men at all, but is approved for MSM and transgender men, women and heterosexual men. And injectable cabotegravir is approved for all groups. The follow-up care for this is different for the oral versus the injection. Let's start with injection. For the injection, it's recommended you get an antigen antibody test and an RNA assay a month after the first injection, and then every 2 months thereafter. With every 4 months, you would add additional bacterial STI screening for those who are sexually active, and if every 5 months for heterosexually active cisgender women. For oral FTC TDF or oral FTC TAF, the same recommendation that we just described is there for every 3 months, not every 2 months. There is great discordancy in the United States about the use of RNA assays for oral PrEP, though I think there is less equipoise or less hesitation to be using it for injections. And then also for the risk with TDF, every 6 months to make sure you're checking renal status, and every 12 months as well. Let's go over oral PrEP daily and on demand. For oral PrEP, we know that there's TDF FTC, and we talked about that, on demand, FTC TAF. The eligibility requirements are that a person has to have a negative test within a week before prescribing, no signs or symptoms of acute HIV infection, and the GFR is greater than 60 for FDC-TDF or 30 for FDC-TAF, and no contraindicated medications. These studies were, this recommendation was founded on the DISCOVER trial, which showed a lower incidence of people on both TDF and TAF, with a arithmetically lower incidence on FDC-TAF, but not a statistically significant difference. We know that there are improvements for people who use TAF compared to TDF of bone mineral density and issues of patients with low GFR. So if that's relevant to your patients that you're taking care of, that they need PrEP and they have low GFR, or there's issues about concerns about bones, if you can get FDC-TAF, it's worthwhile to look at that availability. Overall, the efficacy of these oral regimens is excellent, greater than 99% with rectal exposure, 94% with vaginal exposure, but adherence is critical. And so whatever we're doing, we need to support adherence for the patient, to let them encourage ownership, that they feel like this is their regimen, they're doing what they believe is important, and that kind of adherence is fundamental to success. A study that looked at this in pregnancy looked at the use of oral FTC and TDF, and you can see pregnancy outcomes of 93%, and immediate PrEP was non-inferior to deferred PrEP for safety outcomes of preterm birth, small for gestational age, or any adverse pregnancy outcome. And so this has been shown, if a woman gets pregnant while she's on oral FTC TDF, it's quite safe. There are strategies that may help patients with daily oral PrEP, to find things in their life that you can match the use of PrEP to have compartments with pill trays, phone apps for reminders, to have a peer that they take PrEP with. These are all options that help people to match something in their life so that they can make sure they take PrEP. There's some forgiveness if you miss some doses. It's best not to do that on consecutive days, and there's been estimates to say that you need to take at least 5 doses out of 7 in a steady state. But it's important to stress to patients the need to do this on an everyday basis. The time to protection, you can see that for rectal and vaginal exposure, it's likely to be achieved in 7 to 10 days, but we're not sure about that. And it may take longer in cervico-vaginal tissue or in blood. So there are differences in the latency of onset until that occurs. So for men having sex with men, at least a week. For heterosexual women, thought to be at least 3 weeks. Now, how do you choose which to select? For most of you, the choice of FTC-TAF is not going to be an option, and so the issues are not going to be as relevant. But just for the sake of conversation, if there's concerns about bone mineral density or other issues, or GFR, you might think about TAF. But in general, TAF is not approved for women, so FTC-TDF is the only regimen you use in those settings. On-demand PrEP 211 is used only with FTC-TDF, and it's used only with men for the most part. And what this is, if you've had unprotected sex within 24 hours, you take 2 pills within 24 hours, then you take 1 pill a day later, and the second pill a day later. If it's been more than 24 hours that you realize this, it's recommended you take 2 pills and then 1 pill for the next 3 days instead of 1 day. On-demand PrEP should not be used in heterosexual women, transgender men and women on estrogen therapy, IV drug users, or people with HPV infection. This is a study showing the benefit of 211, and suffice it to say that the overall incidence was lower in the group that used on daily PrEP, and equally lower in the group that used on-demand. So in that setting, it was not, from an efficacy point of view, that different than people who did daily PrEP. Now, let's say you convert. This slide is intended to help you understand what you do if you're on oral PrEP when you become HIV positive. And the point is, you would go on an integrase because you've not been on that before. Your PrEP in oral PrEP is only going to be NRTIs. And so you'd go on bictegravir or dolutegravir plus either TAF or TDF, depending on what's available, plus emtricitabine or lamivudine. I think most of you would be doing dolutegravir, TDF, and 3TC because that's what's available. and that would be totally acceptable for those people who break through on oral PrEP. Now let's talk about injectable PrEP. Injectable PrEP is cabotegravir. It's given every 2 months. It's recommended for both transgender men and women and heterosexual men and women. To be eligible, adults and adolescents greater than 35 kilograms, a negative HIV and antibody test. Also, labels suggest that you should have a confirmatory HIV RNA assay before every injection and no signs or symptoms of acute infection. HPTN 083, the reasons why people chose this, for the most people, they want to have, most people don't want pills and they want to take an injection. It's not just the length of time. About 20% of people thought it was more efficacious, but a lot of times people just want something that's more convenient. On the other hand, people who choose oral don't like injections, or they're not so worried about the effects, and they're not worried about perhaps elements of the resistance. So the point is, the use of injections and oral PrEP are going to allow you to treat a wider latitude of patients, because not everybody's going to feel the same way about what they're going to do. What you see here is that the results of the comparison of oral cabotegravir in studies looking at both men and women, HPTN 083 and 084, indicated such success rates compared to FTC-TDF that in both studies, the DSMB recommended termination of the blinded phase. You can see here the results showed significant differences in the injectable for both in the updated primary blinded period and in the other analysis in both men and women. And so this statistically significant difference, showing much significantly less infections with cabotegravir, led to the approval. It doesn't mean that oral TDF is still not beneficial, because most of the patients who failed oral TDF were issues of adherence. It just says when you compare all the populations together, there was statistically significant performance with the injection, both men and women. When you look at the incidence in changes in bone mineral density, you do see some changes, some declines in the group on FTC-TDF that you don't see with cabotegravir. So whether this decline is clinically relevant for the population for the time they're going to use it, but there are some side effects with the oral regimen that injectables don't have. If you take patients who were on gender-affirming therapy, anyone who was on hormones, there was no difference in the incidence, and so initial findings in the subset suggested that gender-affirming hormone therapy did not affect cabotegravir concentrations. So the estimated time from initiation of injection is still not totally clear. We just know that we start with, in the first month, an initial dose of 600 milligrams. The second dose occurs 1 month after that. It's thought that for the first month you have to use some sort of duplicate means of protection, but after a month you're protected, and then every dose thereafter is every 8 weeks instead of every 4 weeks. Discontinuation, when you discontinue, you need to help patients understand that though they've stopped the injection, the medication stays in their system, and so it's unclear how long it stays in the system. You have to follow them up for at least a year, and you have to assess their ongoing HIV risk and prevention plans. And for many people, it will require oral or some other form of PrEP during that period. They're off of the injection because of that tail. And so the intention is to, within 8 weeks, because that's how long that you know that you're protected, you've got to start some sort of other protection to help people along that path. This is data that I've participated in, looking at a cohort of patients from 2002 to 2024 of patients who were on long-acting cabotegravir, and you can see that we had a significant number of patients who we were able to look at. In our population, about 77% were male, and what we found was that the durability, the median follow-up that we had was 7%, and over 80% of the patients remained on cabotegravir, with only about 1 in 5 discontinuing. There were no seroconversions post-discontinuation. There were people who had delayed injections. 16% had some injections, 3% had missed injections. When we looked at the testing that was done across the board, HIV screening was performed for more than 50% of all of visits in 93% of individuals. So in other words, almost all of the patients had at least half of the tests they were supposed to. HIV RNA tests and antigen antibody tests, which is what was recommended, was only done in about a third of the population with no seroconversions. We're not recommending that you not do the proper testing. We're only saying that in the real world, a lot of people were not doing the testing as often as they were supposed to, and there were not ill consequences that were seen. We still recommend to be doing that testing, both antigen, antibody, and RNA, when possible for patients starting long-acting injectables. There are breakthrough infections. We know that they're rare. All of the patients who had these breakthrough infections had integrase RAMs. The risk of selection of these entities is tricky. Undiagnosed, it could be that we didn't know that people were HIV positive when they started cabotegravir, or it could have been that there were ongoing, the patients were able to get infected while they were on the medication, that Levi syndrome we talked about. And so this is still an ongoing issue, but we know that there are breakthrough infections. Again, for people who didn't know they were positive when they started because maybe their test was falsely negative because they had a recent exposure that didn't register a positive test, or people who got infected while truly on therapy. What to do in those situations? Instead of an integrase and nukes, which is what we did for people on oral PrEP, you go with a protease, or you could use a non-nuke as well. So darunavir boosted with ritonavir or cobicistat, and you potentially could also use a non-nuke if it was not, people didn't have that. And then you would use either TAF or TDF or emtricitabine or lamivudine. Same-day PrEP considerations. Not used much in patients on injectable, not ideal for patients who are ambivalent about starting PrEP. Patients, you need to have a way that you can be sure you're seeing them, not for patients with any acute HIV. Avoid tenofovir-based same-day PrEP in case you're worried about renal disease. Payment methods are important. But the idea of same-day PrEP is occurring in some places, and you have to decide if you think that chance you get a patient in your clinic is a place that you should be offering it. It might be something that you'd want to consider. Future thoughts. We know that lenacapavir is coming. This is every 6 months. The PURPOSE study has shown the benefits of lenacapavir, as well as other regimens, including antibody rings, dapivirine rings, and inserts. The PURPOSE study, as I talked about, is a study looking at lenacapavir every 6 months compared to both oral TAF and oral TDF. This was presented this past year, and what you can see here is that HIV incidence in this group on lenacapavir was 0, with a high degree of background HIV incidence, and you see low rates of both TDF and TAF in that group. So lenacapavir had 100% efficacy, and it was superior to the background incidence as well as to the breakthrough on FDC and TDF. So this lower chance of HIV is important. Injection site reactions were small and not that common. Lenacapavir is going to become an important issue going forward into PrEP. It's probably going to be approved in the States in the next year. It's unclear how quickly that'll migrate over to Uganda for use, but it'll be an important issue because of the less frequent need for dosing every 6 months and a well-tolerated safety profile. So that concludes the talk. Please, you'll see an electronic initial evaluation. Please make sure to answer this, to give us feedback, as well as what you thought of this program for future programs. And I thank you very much for your involvement. Thank you very much.
Thank you very much, Dr. Ilion, for that insightful presentation with a wealth of information on PrEP for HIV prevention. We are privileged to have our next speaker in-house, and he will be speaking about HIV virology and updates on the HIV-1 vaccine. Welcome, Professor Pontiano Kalebu, who is the director of the Uganda Virus Research Institute and director of the MRC UVRI Uganda Research Unit. He holds a medical degree from Makerere University, a diploma in immunology, and a PhD from the University of London. He has served on several committees, including the WHO HIV Vaccine Advisory Committee, the Global HIV Vaccine Enterprise Coordinating Committee, the UNAIDS Science Panel, the AIDS Vaccine Advocacy Coalition Board, and the NIAID HIV/AIDS Clinical Trials Strategic Working Group and was chair of the African AIDS Vaccine Program. He leads a number of national and regional networks. He's Uganda's representative, the EDCTP General Assembly. He's a co-director of the African Partnership for Chronic Disease Research and the co-director for the Uganda Medical Informatics Center, a computational resource offering data storage and analysis capacity. He also chairs the National HIV Drug Resistance Technical Working Group under the Ministry of Health and is a member of the National Antiretroviral Treatment Committee. His main research interests include HIV vaccine research, especially understanding protective immune responses, HIV diversity, and resistance to antiretroviral therapy. He has authored many research articles and books related to health sciences, medicine, and surgery. Welcome, Professor Kalevo.
Good afternoon, everyone. Thank you for the introduction, although a little bit outdated. For instance, I'm no longer the director of the MRC Viera and London School. I stepped down this year after being director of that unit for 14 years. But I'm still director of Uganda Virus Research Institute. The new director of the MRC is Professor Moffat Nyirenda. But I'm very happy to be here to give this presentation. These 2 weeks were dedicated to JCLC. Yesterday and this morning we have been attending the CARES meetings. I chair the Steering Committee of CARES, and we had a very good meeting which ended today. And congratulations to all those who have participated in the CARES study. I know the results of the 96 weeks, but we are not supposed to disclose follow-up. But I was invited to talk about HIV virology and updates on HIV vaccine development. I'm sure the past 2 days, it's been exciting, a lot of development in treatment, in prevention. The talk that you have just heard, lenacapavir, near 100% protection. So quite exciting in terms of prevention and management of patients. And I think we are all happy, those who have been in the field for many years, when we started and there was nothing here to give these patients. And we are looking towards the ending the HIV/AIDS as the public health issue, 2030, if we do well. But in order to put HIV and AIDS behind us, I think there are 2 things the scientists are looking for. One is the cure, and it's good to see that JCLC, again, is now actively involved in the cure research, and the other one is vaccine. So those 2, we are not here today. And I don't think we can say we can put HIV/AIDS behind us without really having either a cure or a vaccine. For us working in HIV vaccine, we still have 3 challenges. We don't have a vaccine, and in the presentation today, I was requested to talk about the latest on HIV vaccine research, which I'll do, and virology. And for virology, I'll just give you a little bit of what we're doing that is relevant. This slide, for those who are in HIV, I think it has been presented for the last 40 years. The challenges remain the same. the immune responses needed to clear the infection are not well known. For many of the infections where we have a vaccine, you get infected, measles, even COVID, many people recover. Even Ebola, that's a Marburg, those very viral hemorrhagic fever, some individuals recover, and you can find something in the immune system that correlates with the protection that anybody designing a vaccine will imitate. But for HIV, we don't have that. Nature, we need to do better than nature, because nobody, if you get infected without treatment, you'll just go down with AIDS. So even the nature itself is failing. So you need to do better, and also to understand exactly what you need. We know that neutralizing antibodies are important, and I'll say more about that. And if you induce them, you can, as one of the studies that was done, you can offer some protection, but getting them is very challenging. The virus gets integrated into the host DNA, and it makes it difficult to clear. It's a chronic infection. And of course, it infects the T cells that are quite important, and macrophages in our immune system. The other challenge that we have is that the GP120 that is needed for attachment to the CD4 and entry and to the other core receptors is very heavily glycosylated. It's a protein, but there's a lot of carbohydrate molecules around it that prevent the antibodies that are produced to really get attached to the GP120 to prevent infection. So glycosylation is important, and the right epitopes are a little bit shielded, not very easy to see. Those are a few challenges. But as we move forward, trials will be very difficult because of the declining HIV incidence. If you give all that has been presented today in a study where you're looking at HIV vaccine efficacy in high-risk groups, you provide the PrEP, you provide all the education, the counseling, and the rest. So it's going to be challenging. And we have seen it in the study we have just completed. PrEP must be included in the design and the conduct of efficacy trials, which can be challenging. This slide shows there have been so many candidate vaccines that have been designed in the lab, phase 1, phase 2, and what I've listed are only those that have gone into efficacy studies from 2003 to the more recent one that we have conducted that ended last year. And all of them have not shown effect. Many were stopped due to futility, and only one in Thailand that showed some modest efficacy of 31%. And when another study was conducted in South Africa to try to use the same concept using the ALVAC and GP120, unfortunately did not protect. So even that, so it's been quite disappointing. One of the last one that has just been published was the Mosaic HIV vaccine that uses a vector, adeno-26, whereby some different antigens, envelope, GAG, and the rest have been inserted and designed to address the diversity of HIV, Mosaic, through computer algorithm. And a lot of work was done with this vaccine, and animals, protection, small studies, very good immune responses, and then two large trials, one in South Africa, which is here in Bokodo, and another one in Latin America. This one was in a high-risk female, getting excited, but again, the results showed that this vaccine did not work. Yet a lot had been invested. So what you see in animals works very well in animals, challenge studies, but you go into humans, is completely different. So that's one other challenge, is that really having a very good model that can filter and say, this vaccine is really good to go into humans. is a challenge. Most of the vaccines that have gone into large efficacy studies, they have gone through all those steps, including some challenge studies and showing some protection. But in humans, it's different. This very study, they have gone on to try to see, for those where there was some protection, is there a difference in the case control study to try to look at some correlates of protection. That was done in the Thailand study where they looked at correlates of protection in a case control study, and they found that antibodies to the V1, V2 were associated with some protection. Here there wasn't much, but again there was that trend that if you looked at antibodies that bind to the V1, V2, there's a trend towards protection, not confirmation. Hence the conclusion of this study saying maybe when you design a vaccine, the V1, V2 part of the virus is relevant. I'll talk about our study we have done. We have just completed, called the PrepVac. It was a 2-in-1, a phase 2B study, where we conducted a vaccine efficacy study, but also we provided, we studied PrEP. And the talk you have just heard, you know, the TAP FTC is not yet at least licensed in heterosexuals. It is used in the gay community, but not licensed, unless there's new information, but it's not yet licensed. So when we did this study, it was a 2-in-1, and these are the collaborating centers here in Uganda, and we did it in Masaka, in Tanzania, in Mbeya, and Dar es Salaam, and in Maputo, in Mozambique, and Durban, South Africa. The key, we really led this study because we were coordinating it, we were the PIs, we did all the data was done by us and Tebe, and also the immunogenicity endpoint. It's really a study that, the first efficacy study in East Africa, HIV vaccine efficacy study, and it was funded by the European Union, EDCTP. So we started around year 2000 to do this study. You have had the results of this study. Try it. Have you? Yeah? You have had. So I just have a few slides because I think we presented it at the AIDS conference in Munich. Results, and this is the design. We had, the reason we chose these vaccine candidates, the DNA, HIV, very nice. We had done phase 1, 2 studies, very immunogenic. And we said, let's use it also using AIDS-Vac. And that is the same vaccine that was used in Thailand that showed modest protection. So at that time, we were still excited about the work in Thailand. So we did it, DNA, AIDS-Vac, then so DNA, same DNA, with another GP120, with MPLA as an adjuvant, and then MVA. Compare that with the placebo. So 1-in-1 randomization, plus placebo. But we also provided, as you can see down there, PrEP, Descovy, and Truvada. And we gave all individuals. And what we did, because in the early period, when we were vaccinating, those are 4 vaccinations, we said, let's give PrEP during that period. We stopped PrEP at the time after we have given the 3rd vaccination, where we think the vaccine is protective. And then we told participants to go into the standard of care in the different countries. But we, as a study, we provided PrEP, and we randomized some to get Descovy and Truvada to get some information, again, of these 2 PrEP in heterosexual. We shall know the results of this PrEP next week. So next week we shall know the results of the PrEP, but we know the results of the vaccine. So we did, these are the baseline characteristics. Jen, you said you know it? So you can see here, there's what we call a random allocation of 1-to-1-to-1, which I mentioned. Then the other side, 1-to-1 and 1-to-1. When we were doing the study faced some challenges. COVID came, we had to pause a little bit. And so a few individuals were really outside our window. And also one of the products, the MVA, had a problem. And now luckily we had planned it as an adaptive study. If we find one vaccine is unlikely, you can really adapt the trial. So it was adapted. So we changed during the study from 1 to 1 to 1 into 1 to 1 because one of the vaccine became unavailable. So the data, but at least we were lucky in that for all, either it's 1 to 1 to 1 and 1 to 1, we were able at least to analyze and be able to find a definitive whether these vaccines are working, the DNA and the ACE and the DNA and MVA. So these were the allocations, the numbers. As you can see, the other side, which has 1 to 1 to 1 and 1 to 1, there are more numbers because we stopped the randomization in 2-1 of the studies. No details given, but I will just give you the results because we have presented these results and efficacy, DNA AIDS vaccine. When you look at the overall, we had 14 HIV infections, and that is about 1,266 person years of follow-up, and the incidence of about 1.1. That's overall. Yeah, that is the combination of giving those who gave DNA and AIDS vaccine. And those in the placebo, 3 infections. In the vaccine, we were shocked, disappointed, and said, what is really happening? Is it a mix of things? Yeah. Is the analysis they put the placebo and the vaccine the other way around? It was very, very, but it was really checked and tested. And if you look at this is secondary modified intention to treat follow-up starting at visit 2. So those are placebo again. That's what I've shown, and AIDS vax, 16 infections. You can see the hazard ratio, 3.26. You look at the DNA MVA, the same trend. Yeah, overall, 11 infections, placebo 2, and again it is we did not sleep. We did not sleep because there were lots of worries. Yeah, one of them, it could easily. Many colleagues who are working in HIV vaccines, we presented to many before we went to Munich, colleagues in HVTN and all that, so that they don't accuse us that you have these results. This can kill vaccine field. It can kill vaccine field. People will just say vaccines may be a risk. So we have to be very, very careful to understand really what is going on. DNA, MVA, and you see this? The same trend, even the DNA MVA with the same trend as a read 2.0. It's very disappointing. The key message we had, it was clear the vaccines did not reduce HIV infections. But what we thought, because we could not interpret it, we are still doing some studies to find out what is happening. But the confidence intervals around the hazard ratios were so wide, so we cannot really draw definitive conclusion about what it means to find more infections in the vaccine and less in the placebo. And the rate of infection, what surprised us, the rate of infection generally was very, very low, even the placebo. Because when we planned this study, we planned for higher incidence, something that is near to what we saw in the PrEP studies that were done here. But this was quite low in so low infection generally, small sample size, wide confidence, overlapping confidence intervals could explain. So, and when you look at PrEP and all that, there's no difference, and the analysis is continuing. No difference whether those in this vaccine took more PrEP, placebo more PrEP. So very quite challenging. Not so, disappointing. And that is likely to be now the last efficacy trial for a long time. Yeah, we are not likely to have any efficacy trial because there is no product that's near. So we have gone back to the drawing table. And I want now to talk about a little bit on the neutralizing antibodies and those why we have gone back to the drawing table. Neutralizing antibodies are important. And those areas of the envelope where they are, my talk was supposed to be 10 minutes. Oh, okay. Let me quickly, I will skip some of the slides. Antibodies, some of these regions of the envelope where the antibodies attack the CD4 region, the V1, V2, and the rest. And in one of the studies, the antibody mediation prevention studies that was done in South Africa, where they gave one of the antibodies, VRC01, that is supposed to be against the CD4 binding region. Although the results were disappointing, but more analysis indicated that actually those individuals who this vaccine antibody was able to protect against infection of the viruses that this antibody neutralizes. Those that pass through were those that the antibody doesn't neutralize. Meaning that then the concept works, antibodies can prevent infection if you have the right one. The challenge is diversity. So that study, when it was analyzed, was shown, and gives us hope that you can get some antibodies. So that's one of the studies we're doing. We're characterizing our viruses in Uganda that are transmitted, because those are the key ones that any vaccine or antibody should attack, and also to look at sensitivity to neutralization. This is, you don't need to go deep into this study, slide, but it just tells you when we look at individuals, viruses that have been transmitted, we call transmitter-founder viruses, they are very, very tight, they are clonal, they are not so diverse, which has been seen elsewhere, and those are the ones we need to target. And we have done studies to look at neutralization. And again, to summarize this slide is that when you look at our current viruses, what we call contemporary viruses, against, and you compare with the historical viruses collected some years back, you find that a lot of the antibodies that we have now are not able to neutralize as efficiently these current viruses as before. So it shows the virus is really evolving. And what we have now that people are using to design vaccines may not be relevant at this particular time. So this work is quite important. Vaccines have to move with the changing virus. And we have now developing the capacity now to develop our own monoclonal antibodies, working with others, so that we can design monoclonal antibodies to address to our current viruses, but also use those monoclonal antibodies to look at, to identify the targets that a vaccine should induce. Yeah? So that approach is quite important. The newer approaches, people have gone back and they're looking at different approaches, back to the bench, using what they call trimers, so that you can have a vaccine that where you have mapped its epitopes, it's designed to be conformational so that it can induce the right antibodies. Germline targeting, some of you may have heard about germline targeting, so that because what we have seen is that individuals who are infected produce a lot of antibodies, but many of them are useless. But some, from some particular precursor B cells, can be good at neutralizing. So how can you get a vaccine that will target those right B cells to produce the right antibodies? So that is what is happening through vaccination, boosting and priming. Then you filter out and you get the right B cells that will produce the right antibodies that are going to neutralize the virus. So germline targeting has moved on, and we have vaccines that have now been tested in phase 1 and they are in what we call experiment. You can imagine we have moved now backwards from efficacy studies to experimental medicine vaccine trials, because we have gone back to the drawing board. I won't go into these studies, but there are some where they are using engineered outer domain of germline targeting, and even our colleagues in Rwanda and Kenya are doing some of these studies. Those were at the last HIV research for prevention. There were some that were presented that are moving forward, germline targeting, to target the right B cells so that you can produce the right antibodies. So I think let me conclude by saying a vaccine will be needed for effective to end the pandemic. We need it. I've shown you that the traditional design of vaccines has not worked. When we got the vaccine for COVID, people said, even the President Museveni said, those working on HIV vaccine are just sleeping. They are lazy. That they are lazy. How can COVID have vaccine and you don't have? You are just lazy. But it's a different virus. The technology used for COVID has been used for HIV, doesn't work. Okay? Mosaic and PrEP trials have shown you they haven't worked. Contemporary viruses, as you have seen, they are less sensitive to the currently available products. So newer approaches like germline targeting are being developed. I end by thanking all our collaborators and funders. Thank you very much.
Thank you. Thank you for that exciting presentation, although some results we didn't expect, or we expected different results. But that's what happens in research, yes. Sometimes you don't get what you expect. So we'll have our final presentation by Dr. Ilion. It's a recording, and then we'll have a few questions. Please keep them coming. We might not respond to all, but we'll pick them up, have the presenters answer them, and send them out. The JCRC team will send them out with responses. Thank you. Over to the team. The back.
Hi, I'm Dr. Richard Elliott. I'd like to talk about HIV prevention and care in adolescents, a very important population, both in Africa and in the United States. Please note the sign-up process to sign in, and we talked about this before for the other talks, so please sign in. Accreditation is necessary, and please, if you want to get CME, please try and respond. This is my information and my disclosures. There'll be an evaluation form that you'll see within 1 to 3 business days. This is very important in order to get credit for your CME, so please fill that out. Learning objectives are to discuss what makes adolescents different, to discuss the barriers to testing and starting either PrEP or ART among adolescents, to discuss also the way we talk to adolescents, our communication approaches, to assess sexual risk behavior, and then finally to select PrEP or ART options according to guidelines recommended in the United States by the Department of Health and Human Services. In order to end the HIV epidemic in the United States, we know that we need to decrease new HIV infections by 75%, increase PrEP by 50%, improve knowledge up to 95%, improve diagnoses, improve suppression rates. But we know that amongst these goals, adolescents are least likely to be aware of their HIV infection, to be retained in care, to have a suppressed viral load, to be prescribed PrEP. So although we have all of these great goals, it's not clear how we're going to translate these goals to the adolescent population. We know that when we look at the demographics, they're not the same in the general population. In the general population of adolescents, 53% are white, but in new HIV diagnoses, 11% in 13 to 19 and 15% in 20 to 24. Black in the general population make up about 14% of our general population of adolescents. But in HIV diagnosis, 56% of 13 to 19 years old and 49% of 20 to 24. And the same, a relative similar thing for Hispanics. So in Uganda, you're going to have to see which population is overrepresented and if there's any differences within your communities. The number of new diagnoses of adolescents is, for the most part, stable in the 13 to 19 group, but increasing in the 20 to 24 group, with the majority of them being with men who have sex with men. Let's talk about how we would approach talking to them in sexual health counseling. We know that adolescence is a developmental time with a lot of variability. Not two 14-year-olds are not the same. There's an ongoing maturation of the frontal lobe which impacts affect and behavior. The need for autonomy and independence increases. And so this creates demands on decision-making process, concrete thinking, behavior, understanding what risk is, understanding exposure and vulnerability. These things you see in early adolescence and middle adolescence, hardly developed. And then in late adolescence, where there's more maturation of frontal lobe and regulatory competency, you can see a little bit more mastery of that. But in that group under 15 or 17, the ability to understand and really cognitively grasp risk is hard to assess, and hard to necessarily demonstrate. The challenges in communication are people have short relationships, they have serial monogamy, they're not sure how to get condoms. Because of their discomfort, they're less likely to be involved in safe sex because of access issues and being able to talk about things. There can be an average delay of a year before they get any contraception. Adolescents are an underserved community, an underserved population, yet one of the leading edges of new infections for HIV. This is a case study of Mackay, a 17-year-old cis male, never tested for HIV. He presents for an HIV test with his best friend who's living with HIV. His test results come back non-reactive, but he has gonorrhea. The backstory is the mom's usually present, but she doesn't come for this. And Mackay is unsure about his sexual identity. Even the fact that he would talk about that would let you know he's having something very different in terms of his conception of who he is. And the ability for a kid to talk about that in the United States, let alone to talk about that in Uganda with some of the stigmatization, would be very significant. So some of this you're going to have to intuit and tell if you think that's relevant. And then, if you think that is, be able to talk about that risk of HIV. You can talk about risks of exposure and both condoms and the use of condoms over time. He talks about using marijuana and not wanting to talk to his mom about what he's doing. So again, using your intuition supplemented by whatever you can learn by talking to the patient will help you determine his risk profile. The factors increasing HIV risk, first of all, let's go from the left all the way to the right. Biologic, there are issues of the mucosa that are not as well developed that can create a less barrier for infections. If you have a concomitant STI, that increases risk. From a cognitive point of view, we discussed the perception of risk, not feeling risk, not being aware that you're at risk. For young girls, not perceiving risk because they're with one partner. Guys not perceiving risk because of the way they view themselves. So this cognitive piece is the second part. Behavioral, their behavior, what kind of activities they do. Do they drink? Do they do other things to alter their consciousness? Do they have irresponsible behavior, so to speak? Are they using substance use? Do they have multiple partners? And then what kind of networks are they in? Are people doing that in their school, in their peer group? Are they have access to education for adolescent youth at risk? Is there the ability for adolescents and young adults to get access to that kind of care? Usually not. So all of these things are going to increase and augment the amount of risk a person would have. Assessing the psychological well-being, there's a couple different ways to do it. This is a mnemonic called HEADS, to ask about open-ended, non-assuming, non-judgmental questions. And this is critical to any communication we have with adolescents. You have to make them think that you're on their side, and there's got to be safety and confidentiality in that communication. The first thing is to look at what's their home life. H, E, education, employment, exercise, eating. H-E, E squared. A, what kind of activities do they do? What kind of affect do they have? D, are they using drugs? And then S, 3, S cubed. Sex, sexuality, safety, suicidality, spirituality. How do you assess this individual? This H, E squared, A, D, S cubed is a way to do that, and we can provide this slide for you as a mnemonic if you wish to use it. Another approach is, do family doctors, do pediatricians often ask about sex? And you can see the answer is no. At best, 30% are asking. By sexual identity, by race, ethnicity, low numbers across the board. So being able to talk about sexuality is critical if you're going to understand individuals who might be at risk for HIV or who are potential candidates for PrEP as well. So for a sexual history, instead of the HEAD acronym, we're going to use the 5 Ps. And the first one is partners. What are the genders of your partners? How many partners did you have? Do your partners have other partners? Ps, practices. What kind of sex do you do? What kind of exposures do you have? P, past history. Did you have STIs in the past? P, protection. Do you ever do anything to protect yourself from STIs? And finally, the last P is pregnancy. So the 5 Ps, partners, practices, past history, protection, and pregnancy. The 6th P, which is often difficult to discuss and usually doesn't happen, is the idea of talking to a patient about what makes them happy, what gives them pleasure, making sexual experience a normal biological function rather than something to be stigmatized. If you can get to the point that you can talk about what they enjoy about sex, then I think you can sometimes, if you can get past people's discomfort about that, you can build a relationship with them that will lead to more truthful and heartfelt communication. So in order to take this sexual history, you have to ensure this confidentiality, to engage youth on other aspects of their lives before going right into sex, drugs, and rock and roll. So talk about their family, talk about their school, make connection with them, get engaged before you talk to some of these issues. Make sure you feel comfortable, or at least you know how to express to them a level of comfort. Adolescents prefer if you're direct. Find a way to put them at ease. I know this may be embarrassing, but I ask all of my questions because I care about your health. I want to understand you better. If you can, have them talk about their sexuality or their gender, but that doesn't always identify who they're going to have sex with. You can ask them about that. You can ask them about sexual behavior, but I think the most important thing is to build a relationship with them, and then whatever you can gain about their sexual behavior from those conversations, that's a bonus. Check your body language. Make sure you don't look like this woman on the right, or the two women, the men and women below that. Provide comprehensive and non-stigmatizing information about this. Let them know that you care. Let them know that sexuality is healthy. You're not interested in knowing if they necessarily have sex with men or women. For the sake of this conversation, you just want to be able to explore this topic. Let's talk about STI screening and testing. We know that the epidemiology of STIs in the United States are quite common. In fact, this population of adolescents and young adults make up over a quarter of the sexually active population, but they account for over 50% of new STIs. When you look at this greater than 50%, you can see that they make up 70% of gonorrhea, 63% of chlamydia, 26% HIV, and 20% of STIs. And the impact of this is particularly true for younger women. So this group is at unique risk for STIs. There are racial disparities and gender disparities, as well as geographic disparities for this as well. So you want to be able to understand if there's differences in Uganda about what part of the country has relative rates of this, and understand the differences between gender in terms of risk as well. The prevalence trends, we see that chlamydia is more common in female compared to men, more common in gonorrhea as well, and that syphilis is on the increase a little bit as well. So these are what we see in the United States. You'll have to track if that's true in Uganda. The current screening recommendations are that for chlamydia and gonorrhea, all sexually active women should consider a pharyngeal and rectal GC-CT and pharyngeal GC. For men who have sex with women, consider chlamydia screening in high prevalence populations. For MSMs, annually at all sites of contact. And for transgender or gender diverse populations, extensive screening as well. For trichomonas for women, consider this in high prevalence areas or high risk of infection. This is not to be done for men for the most part. Syphilis, not done routinely in women or men who have sex with women, but more in the MSM population. For those less than 25, for herpes, consider serologic testing if they're presenting for a STI evaluation for men and women. For MSM, consider type-specific serology. Hep C, to check for all adults over the 18, except where if the HCV positivity in certain regions of Uganda is so low, then you don't need to do that. HIV, we recommend it because it's a high prevalence area for all populations. HIV screening, it used to be that there was a universal opt-out at 13 years of age, but now there are fourth generation antigen antibody tests, point of care testing, and it's important after you get the test to be discuss those results with the patient and to make that as transparent a process as possible. HIV testing in youth, about almost half, 44% of adolescents and young adults living with HIV are unaware, 3 in 7. And young black MSMs in the United States have higher testing rates, but higher rates of unrecognized infection. The reason for this is people don't perceive they're at risk. They don't want to come in and get tested. They're scared of talking about it. All things that would be relevant in Uganda. So the point is to understand that the prevalence in this population is higher than you might expect. And so making sure that you're getting some kind of testing for this population, very important. Let's discuss issues now about linkage to care and treatment considerations. One of the things we know for adolescents is that there's got to be a neutral pathway that the same place you come for treatment is the same place you come for screening. This is a friendly place for sexual health where all of the relative interests and needs of an individual are met. So a true community health center, but for the adolescent, a place that embodies their sexual care. We know that the linkage in care in the United States is not optimal. You see here 76-80% of the total. When you look at 13 to 24-year-olds, you see getting received, but retained only 55, and viral suppression rates being a little lower. So we know that everything is not 100% perfect in the States, and how can things be better in Uganda? Now, adolescents require extra support. They require extra support in negotiating, so there has to be case managers, other kind of healthcare aides, peer aides that can help people. Sometimes these can be done through mobile platforms. Other times they have to be done through the clinic. It's best to find as many ways as possible to reach out and find electronic media for the main place, because that's how people are usually using things. I think even in Uganda, a lot of people have phones, and kids can even start to have phones. So the more ways we can make that digital, as well as making it peer and lower the access, the easier it's going to be. The transition to adult care is not an easy thing for adolescents either. So to going from one place where everything is taken care of to a place where different needs go to different places, the loss of support systems, the lack of health insurance. So these are all things that have to also occur for the adolescents to help them understand the need to transition, to find caregivers, to have discussions, to have non-judgmental places where stigma has no place, where they're open and accessible. This is hard to find in adult care. It's more common in care for kids, but if we're going to engage and retain these kids when they go from being adolescents to adults, that's something that's fundamentally important for this issue. And there are certain voices that are going to be heard during this time. Why do I have to take these medicines? I heard there was a cure. How much are these pills going to cost? My friend has to take 3 pills. My uncle died. Are they going to make me sick? Can I take them if I'm drinking or if I'm getting high? Is it going to change the way I look? How long will I live? What if my friends see it? What will they think? These are voices that one has to anticipate and prepare for. Fears of disclosure. Well, if I tell my mom, she's going to think I'm dying. What will I do if I lose my job? How will I tell my boss? Do I have to tell my sex partner about this? Patient disclosure issues become just as relevant as things you have to talk about with the provider. And anticipating these questions when you talk to patients to help engage them is part of keeping the adolescent into treatment. Now let's focus on PrEP and adolescent. So key considerations. The first, understand the guidelines for who you're treating. For males, whether you're using oral or injectables. For female, which oral you're using, be clear in the guidelines. Make sure the testing has been done properly. 2, make sure you've evaluated adherence and ability of the patient to stay on the regimen. Talk to them about it. Figure out which things you need. 3, think about the sexual health that's going to lead to that. The integration of sexual health into what you're doing. Think about your therapeutic partnership, how you're creating an alliance with this client. Recognize the adolescent's autonomy to the extent allowable by law in your own country. Think about having time with that patient so that you build a stable connection. Be aware of any legal issues. Be aware of safety issues that's relevant for that adolescent. The point is to integrate your entire approach based on a holistic approach towards this adolescent. Adolescents are no different than adults in that you should be doing this for everybody. But the consequences of not doing it with adolescents will be more striking and adherence will falter. So it's very important that you keep this alliance going, so that you keep this connection and you keep this holistic model. So be aware of the medications. PrEP has been indicated for prevention. There are 2 oral regimens, but for the most part, you're going to be using FTC TDF or cabotegravir. So cabotegravir is going to be administered once every 2 months for people more than or equal to 35 kilograms. FTC TDF, you're going to have to check renal status and understand issues about bone. FTC TAF, you're not going to be using for the most part. Know that when these medications are used properly, the risk of getting HIV through sexual contact is greatly reduced by 99%, but that based on adherence, it's going to be different between injectables and orals. Assessing the indications to know the inclusive sexual history of the patient, meaning not just their partners, but their partner's partners. Did they have anal or vaginal sex in the past 6 months with an HIV person? Was somebody who didn't use condoms? Was someone who had a bacterial STI? Or did they just come in wanting it? All of these would provide indications for starting PrEP. For FTC and TDF and FTC and TAF, the clinical eligibility are a documented negative HIV antigen antibody test within a week before, no signs or symptoms of acute HIV infection, very important to ask about that, a creatinine clearance of greater than 30, and no contraindicated medications. For PrEP, documented negative HIV antibody test within 1 week before the initial cabotegravir, no signs or symptoms of acute HIV infection, and no contraindicated. In this one, the shot's going to be given as a 3 milliliter injection, and then 1 month later another one, and then every 8 weeks thereafter. So the only difference between the starting oral and starting injection may be the inclusion of a qualitative or quantitative HIV RNA test. And if you have access to them, it's important perhaps to get it on the first time, but we discussed data that showed that sometimes they're not always as predictive as you would like. There can be a high false positive rate. Which agent you're going to use for MSM, transgender women, heterosexual men, heterosexual women, transgender women, oral FTC TDF. If it's on demand, it's only going to be for MSM. If it's oral FTAF, it's not going to be for heterosexual women or transgender men. It's going to be for everybody else. You're not likely to have use to that. And injectable cabotegravir will be just like oral FTC TDF. It's going to be available for all groups. There are patient voices around this. Well, how often do I have to get my blood checked? Does PrEP protect me from pregnancy? Should I stop if I'm not having sex? Why do I need it? Do I still have to use a condom? What's this going to cost? How long does it take to work? It's important for you to anticipate all of those questions so that when you're talking to the patient, you're hearing the voices in the patient's head, and you can talk to the patient about those voices before they have to ask the question. That will facilitate and create a better engagement for you and that patient so that adolescent feels greater trust. With youth populations, they're particularly vulnerable. PrEP is likely to have an HIV, have an impact on population level incidence. It's going to affect things in your community. It's going to reduce the risk of this. And the rationale for that is if there's concerns about adherence, stigma, ethical, legal issues, if they feel like if they're using PrEP, they can have more unprotected sex. So all things to talk about. The benefits, talk about the reduced risk of infection. Talk about the safety and autonomy they provide. Talk about that they can be used, they don't have to be used your whole life, but just in periods of risk. Talk about the benefit this can make for that adolescent, for the community. Issues to make sure you address, if there's nuances or questions, would be things around gender and race disparities. Looking at these are all markers of adherence. Culture and regional differences about feeling okay about taking care of protection and making a commitment to that. And making sure that there's providers who are accessible and can help with that. The PrEP gap in the United States is a big difference between people with an indication for PrEP. We see 1/3 overall, 2/3 without. And yet when you look at adolescents, 24% on and 76% without. PrEP barriers. There's impact to minors for being able to choose these regimens. Concerns for confidentiality, limited access to testing, lack of access to inclusive, comprehensive sexual care, and low non-adherence among youth on PrEP. So this is going to be a very important thing for you to anticipate and try and deal with on a system-wide level, not just in your clinic. Provider barriers. Providers may not be aware of PrEP. They may have discomfort talking about a sexual history. They may have discomfort providing HIV medication. There may be concerns that patients on PrEP are more likely to take more liberties with their sexual lifestyle. There could be consent laws in Uganda about this. I don't know enough about local laws. And the question of who should prescribe PrEP, that's got to be decided on your local level, deciding how that's set up in your given region, in your different community, to see who's appropriate. Strengthening HIV prevention and care in adolescence, I think, requires developmental, community, structural factors, as well as sexual reproductive health outcomes. This is not just a question of a good doctor-patient relationship, but of a system. We know that adolescents and young adults experience the highest burden of STIs, which also therefore increase their risk for HIV. So access to HIV and STI testing and treatment are important components of HIV risk reduction. We have to look at this as a sexual health program, not an HIV program. Linkage to engagement obviously is critical, so finding ways to lower the barriers, make access something that's easier for patients, and that has to be community specific. PrEP is an important tool for reducing risk for HIV acquisition. There are multiple barriers, but we discuss multiple opportunities for interventions and things that can be done. You will receive an electronic evaluation at the end of this. Please fill that out. We welcome your feedback very much, and we hope this has been instructive for you. Thank you very much.
Okay, thank you very much. Dr. Ilion, we are out of time. Colleagues, thank you to all the presenters. But we will take just 3 questions from the in-house team. I've got the questions from the online team. We'll compile them and have the GSRC team present them to the panelists to provide responses that will be shared. Thank you.
James Opeda, my question will go to Professor Ponshan, who is here. Is your failure to provide vaccines purely based on scientific reasoning or purely commercial, since many of those funding you are huge farmers that are interested in reaping more?
Thank you.
Good afternoon, everyone, all protocol observed. My name is Dorena Leo Camera.
Do you have something packed for lunch? Okay. I know you're listening. Your headphones out, though.
Okay, I don't know whether that's an interference or, yeah. So I'm Dorena Leo Camera, a resident at Makerere University, College of Health Sciences. As my question goes to Prof, I am happy that on the study I had Tanzania being mentioned as born there. So my question is, given the mixed public response to the COVID-19 vaccine rollout, ranging from acceptance to hesitancy, influenced by the misinformation, access, and cultural beliefs, I'm wondering how prepared is your team to address the potential public reactions and ensure equitable access and combat the vaccine hesitancy if this vaccine, the HIV vaccine, becomes available? Like what lessons from the COVID-19 vaccination campaigns are being incorporated into your strategy? Thank you.
Okay, thank you. Was there a hand this side? No. Your hand that side? One. Okay, we'll just have him, and that's it.
Thank you so much. Sembata Bernard from Scaling Up Nutrition and Food Security, complimenting on HIV, TB, malaria. My concern is with Dr. Richard. I seek to be educated more on the target population, because when you said you targeted adolescents, Then later I had transgender persons, MSM, but I don't hear about sex workers, yet they are more at risk as well. And yet at the end, within your presentation, I could hear women being part of the study. I don't know which women exactly that we are at risk. I need to be educated about that.
Thank you. Keep it short, please.
Yeah, thank you so much. I have 3 questions. I'll make them brief. Oh. Okay. So, the regimen of 211 of TAF FTC as a mode of PrEP, I understand this has been emphasized in men who have sex with men. Maybe because of the higher levels of concentration of the TDF in the anal tissues as compared to vaginal tissues. But where does this leave the other parties? Because it seems to be emphasizing protection for people who have receptive intercourse. What about the perpetuators in either cases, even the transgender, the heterosexual women?
Okay, thank you. So we'll have Prof answer first.
So there were 2 questions related to my presentation. The first is about sex workers and women and how to look at groups that would be at highest risk. And we prefer to look at risk based on behavior, not by groups, so that it's less stigmatizing, and so it's more based on what a person is, how they're carrying themselves and what they're doing. So sex workers, because they're potentially having unprotected sex or having sex with multiple people, would absolutely be a group that's indicated. And anyone who's having unprotected sex more than once in a 6-month period in an area where there's high prevalence, such as Uganda or in parts of the United States, would be considered high risk. So we don't tend to look at it based on individuals, but we look at it based on behaviors. In relation to the question about 211, I want to specify that the work on 211 was not done with TAF and FTC, it was done with TDF and FTC. And it was only done with men or transgender women. It was never done with heterosexual women. And so we don't know if it applies to them as well. So it's only for that population of men who are having sex with men or transgender women who are.
Thank you.
I hope that clarifies those 2 questions.
Okay, thank you, Dr. Ilian.
Thank you very much. Why we don't have a vaccine is it because some of these big companies, they just want to reap? I think it's more scientific. Yeah, the challenge is more scientific. But funding is also an issue. It is a risky business now. Initially, I think, even from the beginning, the science has been difficult and not many want to invest. In fact, some are pulled out. And one of the challenges we're going to face is that people may relax and say, we have other tools, yeah, to address the AIDS epidemic. Why continue with this difficult topic of vaccine? So we are also at the same time doing advocacy to ensure that funding continues. Luckily, a lot of the funding is coming from public. I think NIH, US government, has put in quite a lot into the vaccine research, and that should be supported. But some companies risk going there because you invest, but you see the outcome. So I think it's more of the science, but also we know that the funding is not as much as we would have wanted. If you look at the money that went into COVID vaccines in a very short time, and what has gone into HIV vaccines for the last 30 years, I think it's more than 100 times, 200 times into COVID. Because COVID, of course, everyone was at risk. The whole world was on lockdown. Everyone was putting in money. So we need to do the same. If we have more money, I think we may find a solution quicker. So to answer, I don't think there's any under or motive that the companies are doing in order to rip off. In fact, it's the other way. The companies sometimes are risking because you put in, but there's no guarantee you'll really get out of it. Hesitancy, very, very important. We need to learn from what is happening so that we are ready in case a vaccine is available to address hesitancy. And many of us do participate in studies to look at hesitancy in other vaccines. So it is true, it is something we need to look at, to be prepared for, to learn from others, to learn from other vaccines so that we can address this. Working with our social scientists and many others. So it's an important one. We don't yet have a vaccine, but in case we have a vaccine, it is something to look out for.
Thank you very much, Prof. Allow me to ask Dr. Rame two questions from the online team to represent them, but we also kept him online. And one from Dr. Sally: does previous smallpox vaccination protect against mpox? Then number two from Christine Auma: does it mean that HIV positive individuals have to have their CD4 done before being vaccinated against mpox? And the last one: why were there low occurrences of Marburg in children? Over to you, Dr. Rami.
Thank you. I'd like to just make one quick point about sex workers as well. In our country, at least, there are some sex workers who are very rigorous about using condoms with their clients, but don't use them with their boyfriends. And some of those women are more vulnerable from what they do with their boyfriends. So you need to ask both how they behave with their clients and what they do with their lives. So the smallpox vaccine was quite protective against mpox. And part of the reason why I think it's gotten out of control is because we're now pretty distant from our smallpox vaccinations. And the second question was, let me think. You want to just remind me of that second question?
The second question. Second question.
Oh, sorry. The second question: do HIV positive individuals have to have a CD4 done before having the mpox vaccine?
I think that would be pretty situational. We wouldn't recommend that routinely, but if you encounter somebody that you think might be HIV positive, or you know they're HIV positive and they might not be doing their meds, I would probably want to make sure I knew what that count was. But that would not be routine. May I have the third question?
The third one was, why was there a low occurrence of Marburg in children? That's the last one.
So I think in this case, the exposures have been in the Rwanda case, it was largely healthcare workers. I think in that community outbreak that occurred near the Katanga mine, there were children involved. And then they might be more likely to play with the bats.
Okay. Thank you very much. And thank you to all our presenters this afternoon. Thank you to our audience, both those in-house and those online. We've come to the end of this session, and I would like to call Dr. Tamale to introduce the next session. Thank you.
Thank you. Thank you, Dr. Jen. We are, I think, 40 minutes late. So having finished the plenary, we are going to now into the breakaway sessions. The first session will be here, and it will be chaired by Dr. Diana. Then the second session will be on the right. It will be chaired by Dr. George Patrick. And the third session will be on the left. It will be chaired by Dr. Patrick Sebunya. So you are free to join in anywhere that you may wish to listen in. For the people who will be here, we'll be listening in from Professor Victor Musime, and then Dr. Sabrina. So those who want to hear the presentations for session 1, you can stay here. And then for the next, we shall have cardiovascular disease and aging with HIV. That is in session 2. And then session 3, we'll have new advances in malaria. Yeah, and I think that will be in 3 this side. So you can stand up and, join in where you want. Those online can also select where you wish to be. It's free, yeah. It's free will. But if I see so many people here, I'll then have to dictate that some join the other Zoom links. Yeah. So shall we start, we can move. We can start moving. Dr. Diana? Where? Yeah, please take over.
Good afternoon, colleagues. You're very welcome to the pediatric session. Our 2 key speakers, and I invite you all to listen in. The online team, you're very welcome. We welcome Baylor College. We welcome Muju, AIC, and most importantly, JCRC. That you're all here and you're partnering with us once again. Professor Victor, you're very welcome. Professor Victor Msime is an associate professor at Makerere University College of Health Sciences, Department of Pediatrics and Child Health. He is an investigator and senior research consultant at the Joint Clinical Research Center. He has worked as a pediatrician and still works as a pediatrician at the JCRC in HIV research, clinical care and treatment since 2004, and in the last 6 years with sickle cell disease. He previously served as the head of department of the pediatrics at the JCRC, and he continues to be a mentor for the department, or in the department. He is a member of the pediatric ART and pediatric TB subcommittees at the Ministry of Health. He is a member of the committee of the National Drug Formulary at the National Drug Authority. He's the chairman board Kawempe Home Care and a member of the board of the African Network of Care of Children and Adolescents affected by HIV/AIDS. He is a member of the Pediatric Antiretroviral Drug Optimization and Pediatric Antibiotic Optimization Groups with the WHO. His clinical and research interests are in pediatric HIV/AIDS, infectious diseases, child nutrition, gastroenterology, and other non-communicable diseases. Professor Victor, you're very welcome. Friends, welcome him with a round of applause.
Is it on now? Yeah, that's true. Yeah. Okay, so now these are annual updates. So this time we call it the 2024 Pediatric HIV update. the echo has been sorted now. Very good. So we've previously had a 2023 update or the previous years. So this has been going on for several years, and every year we have the update for that year. So the session always continues to be pediatric HIV update. So I'm happy to present the 2024 pediatric HIV update. So this is the order of the presentation that I will use. We will have an epidemiological update, which will be both global, but also we'll also have Ugandan data. Then we will look at updates on pediatric HIV treatment, which will look at emerging DTG resistance in sub-Saharan Africa, and we will also look at the safety, efficacy, and acceptability of bictegravir, emtricitabine, and tenofovir alafenamide. Some quick updates there. All those will be studies for that section. And we'll look at HIV comorbidities, particularly focusing on malnutrition and TB, and then we'll have a summary. So this you may have seen before, the number of people living with HIV, both the adult population and children, but I will focus on the children and say that globally there are 1.4 million children living with HIV, and those who acquired HIV in 2023 were 120,000, the children, that is globally, and then those who died were 76,000. So that means more children acquired HIV than died, so the population is generally increasing, and that cuts across many places. This also is to look at it from another angle. So I've already talked about the children living with HIV, the new infections, and the deaths, but the ART coverage, to focus globally, is 57%. That hasn't progressed. It has always been around there at the global stage. And then the progress towards 95, 95, 95 is still low, whereby we're talking about the 95% of people living with HIV knowing their status, and then 95 of those being on treatment, and then the 95% of that other group also being virologically suppressed. So we're still very bit behind with the testing bit, about 66%, then 86 and 84% in that order. When you come to Uganda, actually things are better in Uganda than on the global stage. The children living with HIV is now 77,000. It's coming down, meaning that we are transitioning a lot more children to adult care or to adolescence or largely to adult care. Most health facilities in Uganda care for the children until they are 18, although the programming is 0 to 14 years. But that means we are transitioning more children than are actually acquiring HIV. So 77,000 children are living with HIV. The new infections last year were about 4,700. AIDS-related deaths were about 3,200, meaning again, like we saw with the global stage, more children acquiring HIV than dying from it. Then the children on ART are about 55,000. Now that ART coverage translates to 77%. I think for a long time, we've not gone over the 70% mark. So 77% is encouraging. We still need to find out how to cover the gap for the remaining ones. And the HIV testing cascade, in this case, the way it was done is the percent of people living with HIV who know their status is 92%. And then the percent of the people living in HIV, the children living with HIV, the percentage generally, not the ones who are tested, but the general population, the estimate is that 92% of the children are actually known, and then 83% are on treatment, and then 79% are virologically suppressed. So you can see there is a slight discrepancy between the 77% and the 83%, but I think it's because of the different data sources. But still it's encouraging. Maybe one can say it's about 80%, which is good. Now, what about the progress towards the vertical elimination of vertical transmission of HIV? Now, we've always had quite good coverage of pregnant women receiving ART. In fact, the estimate of pregnant women who are expected to receive ART was about 78,000, 79. And the estimate was 78,000, but then those who received were about 79,000. But with a range from about 67,000 to 86,000. So we are achieving nearly 100% coverage. So when an HIV pregnant woman presents in our facilities, or even when they tend to be started on ART, which is great. Now, the early infant diagnosis has also improved. Now we are at 82%, which is good. It's improving. It can be better, but it's improving. But the final vertical transmission that includes the breastfeeding period is 6%. We know the elimination target is 5% for a breastfeeding population, so we are still above that, but we are getting there. We are getting there if we continue like this. So the new infections which were averted due to PMTCT were about 19,000, but very, very importantly, the number of children who are exposed to HIV but not infected is about 1 million. So lots of children out there are exposed to HIV but not infected. It's a much bigger population than the ones with HIV. So, and then they have several morbidities that we need to take into consideration. So now let's look at resistance, dolutegravir resistance. I know there is another session which is going to talk a lot more about resistance, but I wanted to focus on the pediatric population. Now, the studies have been done, both cohort studies and also clinical trials, studying the switch. When patients were switched, optimized to dolutegravir-based regimens, different countries did different things. Some needed a viral load before switching, others switched as long as somebody was stable, they would just switch. So in Malawi, a viral load was not necessary to do the transition. So the patients were transitioned and then they followed them up afterwards. So they later tested those who had virologic failure, which was defined as a viral load which was equal over 1,000 copies per mil after intensive adherence counseling. So those had genotypic resistance testing done. So they were able to have a total of 117 genotypes. Now, 28 of them, which was about 24%, had no resistance at all, meaning they were still not adhering. And then 33 had single class resistance. 31% had dual class resistance. 15% had triple class resistance. And 2 of the children, which was about 2%, had 4 classes. So this was including one who had darunavir resistance. So this one really had multiple resistance mutations, and it would really be very difficult to treat that child. Now, specifically, the prevalence of DTG resistance was 26%. That means 31 of the children who had virologic failure while on DTG treatment actually had resistance, which is quite high. And remember, this is program data. This is routine program data from Malawi. Then when we focused on the dolutegravir resistance, nearly half of the children where there was resistance was high-level resistance. So that means they needed to switch from DTG. The other big proportion was intermediate resistance. So only one child would be judged to have low-level resistance. So majority of the children who had DTG resistance actually needed to switch from DTG. And the mutations are listed there. Majority had the R263K mutation, which is observed quite commonly whenever resistance testing for dolutegravir is done. So this data shows that we need to be very more watchful, but a little more about the children who had DTG resistance. Their median age was about 10 years, so they were really getting into adolescence. And 61% were male. Their median total time on ART was about 6 years, so they had really probably gone through a number of regimens. But importantly, they had spent about only 2 years on DTG at the median. So that means they switched to DTG, but whatever challenges they got, they quickly failed on it. So that is quite of some concern. The background regimens are listed there, and it's not surprising that majority were on abacavir and amivudine, because that is what is the common backbone in that age group. So in conclusion, from this analysis, we can see that 1 in 4 children on DTG with virologic failure had DTG resistance associated mutations, which makes us feel, many of us who are in routine care, wherever we are in our facilities, that as we transition to this quite favorable regimen that is once daily, we need to think about the development of resistance and look out for it and address it. Now, a similar study was done, a cohort. Now, there is a virtual clinic that is run largely with most of the people running it in UK, but they receive global consultations, and there are lots of other people who participate in that. So they had their cohort, they get referrals. Even somebody here, if they want, you can send them a referral of a patient for consultation. But in Uganda here, we have our own clinic, which Dr. Nakawesi, it's a committee. I don't know whether it's we call it a clinic. Maybe we should start calling it a clinic. But it's a committee, so we have a national committee that reviews. So the same way we have a national committee here is the same way this virtual clinic runs. So the prevalence of emerging integrase drug resistance mutations was evaluated from these international transfers. They documented any prior exposure to integrase inhibitors, and this was noted to be among 61 children. So the prevalence of the mutations was 31%, a bit similar to the Malawi data, in fact a little higher. So meaning that of the children that were referred, several of them already had resistance. So a bit similar to the Malawi data, the median age was about 11 years, and majority of the children were from low and middle income countries. So 2 children developed resistance, and the one was on first line. The children who developed resistance, 2 were on first line DTG based regimen, and the 17 who failed one second line DTG based regimen, which is probably not surprising. So the clinic, the team that runs the clinic, recommended TAF, FTC, and boosted darunavir-ritonavir, which probably is a favorable one and wouldn't be very different from what we would recommend here. So what about in the CHAPAS 4 trial? You may have heard about the CHAPAS 4 trial that evaluated second line ART options in Uganda, Zambia, and Zimbabwe. And this trial randomized the children who are failing first line ART to either receive DTG or darunavir-ritonavir or atazanavir-ritonavir or lopinavir-ritonavir, and simultaneously also randomize the backbone to either receive TAF or ABC or zidovudine. So the children were followed up, and at week 96, those who had a viral load of over 400 copies per mil had resistance testing done. So normally people use 1,000 as a cutoff, but in Chapters 4 we used the lower cutoff, which was 400 copies per mil. Now, a viral load of over 400 copies per mil was observed in 124 of the over 900 children, which was about 13.7%. And the resistance testing was done for majority of these children in 2 of the children. But the children who had failed while on dolutegravir, or who had a viral load over 400 copies per mil, were 18. So the prevalence in this case, if we were to calculate, is about 11%, still lower than what was observed in Malawi and in the virtual clinic. So both these 2 children were on zidovudine. So there was, one of the children had high level resistance, so the other one had the intermediate level resistance, meaning they were not, at least the one child needed to be switched, depending on whatever was there. But on a good note, no darunavir, ritonavir resistance was observed. So what we saw here is that comparatively, at least related to the cohort data, the high level resistance to DTG was relatively uncommon within the Chapters 4 trial. So what about another integrase inhibitor-based regimen, that is bictegravir, FTC, and TAF? It's already approved for children over 2 years and weighing over 14 kilograms. But this analysis, or this trial, looked at the safety, the efficacy, and acceptability of this regimen in the younger children, those who are over 1 month and weighing 6 to 14 kilograms. So this was part of a bigger ongoing trial within the network. So there were 29 participants that were involved, and these were recruited from South Africa, Uganda, and USA. Some were ART naive and others were experienced. And many of them had a viral load of over 50 copies per mil. So at week 12, when they evaluated, at week 12, the CD4 remained stable, and 88%, that is 22 out of the 25 children that had the assessment, had a viral load of less than 50 copies per mil, meaning that they responded well in terms of efficacy. There were not so many events observed, so only 2 grade 3 or 4 adverse events were observed, and none was considered to be drug-related or led to treatment discontinuation. And then when they asked the caregivers about these tablets for oral suspension, or what one would otherwise call dispersible tablets, 27 of the 29 caregivers, which is about 93%, reported that the tablets were easy or very easy to prepare. They perceived them to be with neutral or favorable acceptability and palatability. So what we can conclude from this is that the formulation of BF-TAF tablets for oral suspension was favorable in terms of safety, efficacy, and acceptability in infants and children aged over 1 month and weighing 6 to 14 kilograms. So that means this formulation can be used in the very young children. Okay, so now, after that treatment update, now we can look at the comorbidities, starting with malnutrition. The recent evaluation which we did in Mwanamujimu, which showed that the prevalence of HIV among those children admitted with severe acute malnutrition was 9.5%. Now the background prevalence in the general population is about 0.5%. So you can imagine, so the children live, if you are to evaluate the 77,000 children against the maybe 20 million children living in Uganda, that prevalence is about 0.5%. But if you are to look at Mwanamujimu, which has only admits only severe malnourished children, the prevalence is about 10%. Now, I mean, that's a very high comparison. So that shows that there is an association between HIV and malnutrition. And in the same word before, an earlier study again, which we had done, that showed that the children with severe acute malnutrition were more likely, 2 times more likely to be HIV infected when compared to those that did not have malnutrition. So that means HIV and malnutrition go together. You see malnutrition, think HIV. And if the HIV is not treated, that means they may go down the line of being malnourished. So this is something to consider whenever you're treating the 2 conditions. Now what about TB? This is a slide that some people have seen before. HIV increases the likelihood of development of TB, both in adults but also in children. And among the HIV-infected individuals, the lifetime risk of developing active TB is 50% compared to about 5 to 10% in those who are not HIV infected. So HIV really increases your chances of getting TB. And if a person has HIV and there are other infections, including TB, then the HIV progresses. So the presence of TB leads to advanced HIV, or the HIV progresses much more in the presence of TB. That's what we learned from this slide. So why does this all happen? There's a cycle here which tries to outline what could happen with HIV in the center, but there are lots of factors that contribute to this. Some are nutritional, others are social factors. There are other comorbidities, not just the TB, but it sometimes leads to the other co-infections like diarrhea and others, which could, in the presence of ART and GIT dysfunction, that cycle, there are many factors that intertwine where HIV leads to malnutrition, predisposes somebody to getting TB, and then TB also leads to malnutrition, and then somebody who has HIV is very likely to get TB and HIV. So it's all a cycle. They are all together. They occur together. So what do we learn from this? So that whenever you are thinking about managing, you think, when you are managing one, think about the other. Consider them. Consider the presence of them when you are treating them. So starting with the malnutrition, so when ART is given concurrently with because when somebody is admitted on a malnutrition ward, you want to give them therapeutic feeds for nutritional rehabilitation. It's not that you always start with the nutritional rehabilitation and then start ART later. But in the context of ART, it's always recommended that while the children are still undergoing nutritional rehabilitation, you should start them on ART. But you should be cautious of what they call the refeeding syndrome. Refeeding syndrome is that when a child has just come and you give them feeds, you need to introduce the calories slowly because the child has been under a state of chronic starvation. So you don't, when you introduce the feeds quite rapidly, then they develop some electrolyte imbalances that affect their outcome. So in that period, sometimes it's not good to start ART in the first few days after admission. But once they are stable, the same way you step up feeds and start other things, that's when it's advised to start the ART. Now the dosing that is given does not take into consideration whether the child is malnourished or not. It's weight-bound dosing. So a child of 5 kilograms who is malnourished and a child who is 5 kilograms who is not malnourished all receive the same dose of drug. So that means if, for example, a 1-year-old who is 10 kilograms is not malnourished, and probably a 5-year-old, 4, who is very malnourished and is also 10 kilograms, will receive the same dose. But do they have the same physiology? I think there is a challenge there. So we know that drugs like the dolutegravir are very highly protein bound. In fact, DTG is 99% bound to albumin. So meaning that if you give a lot of the drug, much of it will be left free, and that could cause toxicity and may not even end up at the site where it is aimed to go. So it's very important that we evaluate whether the malnourished children actually need different drug doses. And there is a study which we are doing at the moment to evaluate the pharmacokinetics of DTG among the severe malnourished children, and look forward to getting the results on that, which will be quite encouraging if we find that we can find new doses for that. But if the doses are safe, then that will also be encouraging. Now, what about treatment of TB in the context of HIV? We know that as children start ART, there is the risk of development of iris. TB iris is the commonest presentation of iris among children. So that means when you're starting children with ART, TB occurs commonly. But how do you dose the DTG? There's a general statement that once you're starting TB drugs, you should double dose the DTG. That's what we do in clinical practice, but does that give you adequate doses? So we evaluated this in the empirical trial. These were infants who had who were on anti-TB drugs and DTG. So we checked whether double dosing was safe and efficacious, and it was. So which is encouraging. So continuing to double dose is okay when somebody has HIV, even when they are infants below 1 year. So in summary, what we have seen is that children continue to acquire HIV in Uganda and elsewhere, but we also note that there have been significant improvements made with early infant diagnosis and ART coverage. With this widespread rollout of DTG, we need to be mindful of development of resistance, so we should monitor for it. And because some studies, especially observational ones, have shown that it is emerging at a significant level. Then HIV, TB, and malnutrition commonly occur together. So when you have patients who have TB or malnutrition, the HIV test should be routine. So when you see a malnourished child, you need to screen them for HIV. You see a child with TB, you need to screen them for HIV. And then also, tests for TB should also be routine among children with malnutrition. So that means things like chest X-ray, gene expert, all those things should be done routinely in patients who are malnourished. So thank you very much for your time.
Thank you, Professor Msime. I think that hand clap was for, I'm not very certain. Thank you, thank you. I kindly request that you take your seat and have Dr. Sabrina present, then we'll have our Q&A after the second presenter. Is that okay with all of us here? Thank you very much. Our second presenter is online and she's ready. She's unable to join us physically, but she will do us good equally, virtually. I wish to introduce to you Dr. Sabrina Bakera Chitaka, a Ugandan medical doctor, pediatrician to be specific. In addition, she's a wife and a mother. She has got specialized training in pediatrics and child health, as well as additional training in pediatric infectious diseases and adolescent medicine. She's a senior lecturer at the Department of Pediatrics and Child Health at the Makerere University College of Health Sciences. She was a Gilead Fellow and then research scholar at the Infectious Disease Institute, where she undertook a fellowship in pediatric infectious diseases and researched on HIV-infected adolescents, and completed this in 2011. She has a PhD from the School of Biomedical Sciences at the University of Antwerp, Belgium. She's involved in conducting basic research in various pediatric infectious diseases, offers clinical care to HIV-infected children and adolescents, most of whom are perinatally infected. She directs the Adolescent Health Training Program at the Makerere University College of Health Sciences. She is the founder president of the Society of Adolescent Health in Uganda. Dr. Chitaka is also an active member of the African Pediatric Society of Infectious Diseases, and she is the author of The Real Pursuit of Excellence. Dr. Sabrina, you're very welcome.
Thank you very much, Dana. I'm not sure if you would like me to share my slides or they'll share them from that side. Please advise.
Please feel free to share. Thank you.
Let me get the Sabrina's presenting. Okay. I'll send you some. Are you able to see the slides?
Not yet. Now we do have your slides on.
Okay, I'm just about to start sharing. My apologies, sorry. And I'm delighted to be sharing this platform with Professor Msime, who has given us a great presentation on HIV and malnutrition. And I'll be sharing with you differentiated service delivery models for adolescents living with HIV. I'd like to share my video. Thank you. So these are global statistics that I'm sure you all know, that by 2022, there were 39 million people living with HIV, and nearly 1.7 million became newly infected with HIV. 630,000 people have died of AIDS-related illnesses, and at this time, I'd like to share my condolences with people at Baila, Uganda, who recently lost a young person who was extremely vibrant. It's sad when we lose young people to HIV, and it's our job as healthcare providers to ensure that we do not lose any other person to HIV come 2030. Again, these are global statistics, and I will not bore you with them, but I want you to know that adolescents and young people are the people who are continuing to have the highest number of HIV infection. And most of these people live in sub-Saharan Africa. The majority of the people who acquire HIV are girls and young women, and so we need to make sure that we address them in a specific and special way. There are many reasons why adolescents are at risk, and I know my colleague already shared his presentation in the plenary, which was quite informative, but I'll repeat it anyway, that adolescents have intrinsic challenges because they undergo pubertal changes, they have brain maturation mismatches, they're also exploratory, and they have identity problems, including of belongingness. They also have extrinsic problems, which could be typical or atypical, like family expectations, lifestyle, family dysfunction. When adolescents' families are breaking up or their parents are fighting, they have complications of their psychosocial presentations. They have increasing demands and also difficulties with their motivation. In Uganda, as you know, we have close to 1.4 million people living with HIV, and nearly 130 are adolescents living with HIV. The majority are perinatally infected, and as per 2019, the prevalence of HIV among adolescents was 2.8%. This is the Baila Clinic, Many of you may have visited it, and it started in 1988 with dedicated pediatricians, and I want to give a shout out to Dr. Dennis Tindiewa and also Dr. Kalyesubula. And the adolescent clinic then started in December 2003 at the Baylor Clinic with support of the IDI and the PIDC at that time. As per 2024, data from the Baylor Clinic showed the clinic had registered more than 16,500 individuals. We know that there are two types of HIV-infected adolescents, those who acquire HIV vertically from mother to child and then behaviorally. We know that most of the behavioral transmission is through sexual means, but we are getting an increasing number of adolescents acquiring HIV through intravenous drug use. Adolescents, as they increase their age and life expectancy, they have developmental-related tasks. And some of these include making or building social and sexual identity, making education and career choices, and gaining autonomy from their parents. But I'd also like to say gaining autonomy from us, the pediatricians. Because as you know, pediatricians are really motherly or fatherly, and we are sometimes like mother chickens. We want to brood over our patients, we want to guide them, protect them, show them what to do exactly. But as adolescents grow, they need to develop their independence from us. And as a result, they would like to develop their own personal adherence mechanisms to antiretroviral therapy. There's been a great evolvement of antiretroviral medication. Way back in the day when I was still a postgraduate student in the early 2000s, we used to give our patients up to 15 different medications. These included various antiretroviral drugs, cotrimoxazole, sometimes even have to put them on TB medications, and it was difficult. But today we are happy to note that the multiple drugs have been shrunk with support of many, many studies that have been done, especially here in Uganda. I know that JCRC is one of the main sites. The PIDC or Baylor Uganda is another impact site, and also Muju and the UVRI, resulting in optimization of treatment and ensuring that our adolescents are no longer taking 15 pills, but just even one pill sometimes. Today, as we look at the test and treat approach, adolescents should ideally be adhering to their treatment. But is that the case? We don't know. We are seeing many children who are failing on their first line and even on their second line, and now some of them are on their third line. These are data from Baylor, Uganda, showing you the viral load support and outputs, and then the different regimens that by the time this data was shared with me, up to 1% of our adolescents were on third line treatment. Now, why do adolescents fail on treatment? I know that I've shared this slide before, and these data don't change a lot. And I did this work with Professor Nicolette Nabukera, and a lot of the reasons why adolescents don't adhere is because of stigma. The stigma may be self-stigma or external stigma, or even stigma instigated by us, the healthcare providers. Then there's poverty and negligence, and more poverty among the caregivers, but also the pill burden. The healthcare providers, sometimes we fail to disclose to these adolescents, and some of the healthcare providers also share myths and misconceptions that are untrue. And then the policy and implementing partners continue not to optimize the providers, to optimize the treatment. So adherence among adolescents living with HIV may result in virological failure. And you know that once virological failure kicks in, the next is immune incompetence, and then the multiple opportunistic infections. So we need to monitor antiretroviral therapy. Viral load, obviously, is the recommended preferred monitoring approach, and it results in switching. The UNAIDS has suggested these as the strategies that we need to adopt, which we are now calling the 95-95-95 testing, treatment, and viral load containment strategies. But there are different things that we need to look at. At the HIV services, are we ensuring that these mothers who are breastfeeding their babies are actually breastfeeding them? And we've done work with adolescents living with HIV and the approach to EMTCT. There's also integration and social enablers that need to be looked at. So as we look at the 95-95-95 strategy, we need to look at it specifically for adolescents who continue not only to fail on their treatment, but also to die from lack of adherence and opportunistic infections. I know you've seen this already, but whichever category of patients we start treatment on, it all starts with HIV testing. At our ward, on Stanfield Ward, which is the Pediatric Infectious Diseases Ward, we continue to see children and adolescents who have fallen through the cracks of our healthcare system. Last week, we had a 12-year-old girl who presented to us and had recently been tested. She had Kaposi sarcoma, which was disseminated. She had disseminated tuberculosis, and sadly, she did not make it. The second thing is enrollment into care. And the third thing, as we know, is initiation of antiretroviral therapy, which is lifelong. I know in the plenary we heard that the treatments are changing. We are now having injectable Kabele, but for the moment, we mostly have oral treatment. Adolescents face many challenges, and one of the challenges they face is sexual and reproductive health challenges, including early sexual activity. Also, HIV transmission to their sexual partners if they are not virally suppressed. In a previous study, which we did 10 years ago, and I believe that this study results could change, we interviewed 420 adolescent girls, many of whom had become pregnant but were not disclosing to their significant others. But of the boys who had gotten their girlfriends pregnant, majority of whom were in a discordant relationship, 100% of them had disclosed. There are treatment issues that we need to consider, including adolescents understanding their own treatment. I'm proud to share with you this picture because it was an adolescent who was finishing his senior 4. He understood how to navigate the computer, and by the time he left my visit on that day, he clearly understood what an HIV virus looks like, where the treatments work, and all this. But are we able to afford education to our patients in this way? Or do we just tell our patients, take your medicine? Why didn't you take your medicine? We need to empower these adolescents on how and why they are taking their medication. So I know that I'll be presenting about transitioning tomorrow, but I'd like to say here that transitioning does not mean change of the health facility or change of location. It needs change of our own mindset as healthcare providers. I already mentioned that pediatricians are capable of treating patients from day 0 to day whenever, when the patients are much older. And I know that as pediatricians continue to treat patients who are chronically ill, we need to change our mindset and stop treating them like small adults or big children, but treating them like adolescents who are becoming independent. There are reasons why transition wouldn't happen, and these have already been discussed in the plenary. Financial independence may be a problem. Self-support for adherence to medication may also be a problem. but also transitioning from the pediatric to the adult service. There's once upon a time in 2007 where policymakers pushed us to transition our clients. And sadly, out of all those who were transitioned, we lost nearly 25 adolescents because where they went, they were not really taking care of them. We've had opportunities to transition our clients in our psychosocial clubs. And the psychosocial clubs were named by the adolescents themselves. They had the Kids Club, the Sharp Club, the Bright Club, and then the Youth Club. But as we continued to provide psychosocial assessment and psychosocial clubs, more and more clubs came up. But I'm reminded of one individual. I'll just call her GN because those are her initials. She got stuck at the Sharp Club for 10 years. And for 10 years, she kept saying, I am still 16, I am still 15. And she kept switching from 15 to 16 because the Sharp Club had the most exciting peer support. Eventually, this lady, who is now about 33, agreed to transition to the Youth Club, and now she brings herself to the clinic and she's confident about taking care of herself. So disclosure is difficult and disclosure affects transitioning. And these are some results. This is an old thing, but I want you to know that during the time of COVID, we had many problems. Some adolescents never got their treatment, and so there were new innovations of seeing patients using the electronic medical records. We continue to see our patients electronically, and sometimes I feel a bit confused. Are we really doing these patients a service, or are we just jobbing? Because if we don't see face-to-face patients face-to-face, we may miss out on an opportunity to treat them or support them. So the treatment cascade, as I said, starts with diagnosis, finding a provider, starting treatment, and the entire goal is to ensure that the viral load remains undetectable. And this is a roadmap to becoming undetectable. It looks like a wavy second ladders kind of arrangement, but in all these things, get in care, get on treatment, stay in care, stay undetectable, requires a person-centered care. Each individual has their own unique adaptabilities. We know that undetectable equals untransmissible, but we also know that U equals U does not mean that the patients have recovered from HIV. And in Uganda, as per 2018, only 63% of our adolescents were virally suppressed. These figures have gone up for sure, but many vulnerable adolescents are continuously becoming detectable. So treatment as prevention has also been talked about, that undetectable equals untransmissible works for as long as undetectables continue to adhere to their treatment and remain in care. Many adolescents are vulnerable to being detectable because of personal and structural instability, and also if they become newly infected with another type of virus, and also if they don't disclose. So what about PrEP versus PEP? It's important for all of us in this room to understand the difference, that PrEP is pre-exposure prophylaxis, while PEP is post-exposure prophylaxis. And that if we are dealing with high-risk communities, we are dealing with discordant couples, we must give them PrEP. PEP, as you know, can be given whenever a patient is exposed, and also when taken correctly, it can prevent the person from getting HIV. So, what are our priority strategies? The first one, of course, as we know, is in identification, in linkage, in treatment and in prevention and retention, and finally, ensuring that the viral load remains suppressed. There are peer-led services, and including YAPS for Uganda and other African countries, but there are also different HIV services which are restricted to adolescents. And these aimed at ensuring that the adolescent is in charge and in control. I borrowed this slide from Tanzania, where they do a lot of mental health care, VMs, safe male circumcision, adolescent camps, economic empowerment, but that HIV prevention education remains at 100%. This must remain at 100%. So as we talk about differentiated service delivery, it's important for us to appreciate that it has to be personalized. And that whereas there's the facility-based individual models like fast tracking the patient, appointment spacing, and then community-based models, which also include the border delivery model, and then the facility-based group models, and which include adherence, and then community refills. All these types of differentiated models should be tailored to the adolescent. And that if you don't tailor these DSDs, you're going to lose the adolescent. So, whichever model you use, whether it is family-centered, family picking up the treatment, a community pharmacy, border delivery, pharmacy refill, fast-track multi-dispensing. At one point, it's important to ask the adolescent, look at this overly crowded city of Kampala, and today it has rained. It's going to be exactly like this. Imagine a border guy taking medicine in a crowded city, in a flooded city, and they may not even reach. So we have to be careful. So this is a community pharmacy. I couldn't find a picture where the adolescent was very short and couldn't reach the pharmacy, but you get the idea. So what about stable and pregnant breastfeeding women? Of course, we know that adolescents must be part of the EMTCT agenda. And we know that adolescents in Uganda continue to be 1 out of every 4 adolescents. So how do we cater for these people? So differentiated antiretroviral delivery models have to be tailored to girls who become pregnant, those who have unwanted pregnancies, those who are in discordant couples, and those who are afraid to be battered by their significant others when they disclose. We have to differentiate for adolescents who have high-risk behaviors and those who need confidentiality at all levels, and ensure that confidentiality means true confidentiality by all of us. And whatever we do, I think it is important for healthcare providers to be compassionate, but also to understand the concept of taking care of an adolescent. We need providers who are knowledgeable, who are non-judgmental, who ensure confidentiality irrespective of what the adolescent tells them, but also where consent is needed, to provide consent. We must listen to the adolescents and cater for their socioeconomic issues, because poverty plays a key role in adherence and in disclosure. We need to look at the schools where these adolescents are, whether they are in boarding schools or day schools, whether they are in co-ed schools or single girl schools or single boys schools, and even look at their transportation challenges. We've had adolescents tell us that they've walked for 6 hours to come to the clinic, and then they have to walk back. But can we find ways and means of fundraising for their transport? There's no point in saving an adolescent from HIV, from an opportunistic infection, and then they die because they are walking and they are hungry and they are going home after picking their medication. We must empower the youth to live positively with HIV and be able to cope and have mental health stability, but also prevent them from transmitting HIV to those who don't have it. So as I summarize, I'd like to say that taking care of adolescents living with HIV is going to require all our hands on deck. It's going to require us to put all our feet in that water and be able to support them from where they come from, and also look at a personified model. So we have to have respect and non-judgmental attitude. We need to understand adolescents as change agents. And I want to shout out to the YAPs. I want to shout out to the peer mentors. I want to shout out to the clinics that truly believe in this competency model. And before I finish, I'd like to say we should all have knowledge and skills to take care of adolescents. Adolescents living with HIV in resource-limited settings such as ours are going to be the population that's going to live with HIV for the longest span of their lives. That means that as they continue to be on antiretroviral therapy, they are going to be at risk of developing complications. They are going to be at risk of getting non-communicable diseases, including mental illness. And so we need to be geared towards supporting them as they grow. It's important for us to develop targeted interventions, such as optimizing their antiretroviral therapy, whether this antiretroviral therapy is their first line, second line, or third line. And finally, I'd like to say that as we take care of adolescents living with HIV, we must personalize their differentiated service delivery models and individualize them. And I'd like, obviously, to acknowledge my parent department. Professor Musime is my head of department, and he continues to allow me to work at the Baylor Clinic. I'd also like to acknowledge Baylor, Uganda, where I work, the adolescents and caregivers who continue to teach me and others how to take care of them better. But to thank the update meeting and the JCRC for continuing to engage me and be part of this amazing conference. Thank you very much for your time.
Wow, 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 wow. A bigger round of applause for our two sensational speakers. Thank you, Professor Msime. Thank you, Dr. Sabrina. I am very aware it is 5 p.m., but I know there are people dying. You know that statement of dying with questions, burning with questions? So I'll give the physical an opportunity of 3 questions, then online will be 3. As you ask, quickly introduce yourself by name and where you work, not birthplace. Thank you.
Thank you so much. I appreciate all the presenters of the pediatrics for the great work done. I'm Sembata Bernard, working with Scaling Up Nutrition and Food Security for Youth, Adolescents and Children, Civil Society Network. I'm happy about the interventions, and my first one goes to the last presenter. I'd love to know Dr. Sabrina. Thank you for the great interventions, but and also the passion. Really, when you speak, you really see the passion for the children and adolescents. And my concern goes to the area when you're ending, you ended well, coping up with mental health, HIV care, prevention, and I would love to be educated more on how we can integrate sustainable access to nutrition and food security into the entire programming for adolescents and their households. Because I understand Baylor always give them nutrition kits, but draw a picture to a rural-based person or people who can't help themselves on integrating these best practices that respond even to climate change programs like smart climate change agriculture programs, kitchen backyard gardens, family backyard gardens, and also Baylor setting up a model. We can even support you to set up a model at your health facility, and it becomes a model that when clients come, can really see it, learn from it, because it may not help every client to set it up, but you can support them. Maybe in your next grant, support every grant with the agricultural kit, whereby you can start up that smart climate change garden. Thank you.
Dr. Sabrina, kindly hold on. I'll take 3 questions at a time. This gentleman is definitely working with a nutritional program. Our dear speakers, I think I thanked on your behalf, so Please kindly accept that we keep the questions shorter. If you have 5, pick 2. If you have 3, 1. Thank you.
Thank you. I'm called Brown. I work with JCRC, and my question is Dr. Musime. You painted a picture about, my question is with regard to DTG resistance. My concern is that as from your studies, there's indication, evidence to show that there's growth in the resistance to DTG regimen. My concern is what are the strategies that have been put in place when there is really serious failure and there is a significant increase in resistance to DTG. What are the options? Then the other question is that in your study in research with regard to chapas, you said that the resistance was not noted in the chapas study. Apart from making that statement, you did not clarify why there was no information about observation of resistance to the chapas with regard to DTG. Kindly clarify.
Thank you, Brown. Third question.
Professor Victor, the nutrition HIV TB pathways, where can we get more info so that probably we can look out for more? So you said there is usually some correlation. Maybe, I know in this room we may not be able to elucidate more, but if you can, refers to how we can read more, that would be excellent. For you, Dr. Sabrina, I am a regular visitor to many brothels for various motivations. And I have observed that there is a miscommunication, especially when it comes to PrEP. I don't know what is being said or what needs to be done. I said brothels, and for some may understand what a brothel basically refers to. Thank you so much.
Thank you. Dr. Sabrina, could you kindly respond to your question?
Thank you very much for the questions. To our friend who, Bernard Sembatia, thank you for proposing to give us those agriculture kits. As you know, 4 out of every 10 Ugandans has acute food shortage. And I want to say here that a hungry man is an angry man. And when a man is angry, they are very unlikely to adhere to their treatment. So for sure, if you can provide, I could link you up with a nutritionist at Baylor, Uganda, and I know that Dr. Jane Nakawesi is in the room. I'm sure that if you're able to get in touch with her, she could get more information on how best you can support our adolescents, but not only adolescents, even the parents and the families that come to Baylor. If families can understand that you can actually have cottage industry for food and not starve, then that's even a big way towards curing them. Then someone said he was a regular visitor to many brothels. I hope he's not a customer. I'm sure he's not. But anyway, for people who are MAPS, most at-risk populations, if they are HIV negative and they are in a high-risk activity, then they have to get onto PrEP. That they must get onto PrEP and adhere to PrEP, but not only use PrEP, use a double protection, including using condoms. Thank you.
I think now I can take the questions.
Yes, thank you, Dr. Sabrina. Yeah. And there are 2 questions for Professor Msime.
Yes, thank you. Brown, thank you very much for your questions. There were, one was, both were on DTG resistance. So you're wondering the fact that it's being observed to be emerging, what strategies can be done to curb this? You know, when DTG was introduced, it was, it came in a good way because there was, it came with a high resistance barrier that was observed in previous studies, and also the virologic response is quite good. So documenting the resistance like this helps for people not to relax, because there was a tendency for some people to feel
This drug has a very high resistance barrier. It's once daily and it's forgiving. For non-adherence, I think that's not entirely true, that it's forgiving. So maybe somebody can take treatment and you may not monitor that closely. Yes, let's continue to do the routine viral loads every 6 months. And whenever somebody develops a high viral load over 1,000 copies per mil, let's intensify adherence counseling. And if we still see that they are not suppressed, then we do resistance testing. So it's important for us to do the monitoring and surveillance. Surveillance is usually for drugs, but that kind of monitoring is very important. Enhanced monitoring, to be on the lookout. And then options, yes, there are options. As I mentioned, the trials that have checked, or even what happened in the virtual clinic, they would switch to darunavir, ritonavir based regimens. So when somebody has failed DTG, the darunavir would still be able to work. Then you asked about within CHAPAS 4. Yes, let me clarify the statement. 2 children failed on DTG, 2 out of the 18. So which makes it about 11%. The ones who had no resistance, it was to darunavir. So there was no resistance to darunavir. But 2 patients out of the 18 who had virologic failure had DTG resistance. And then somebody asked about the HIV-TB malnutrition interaction. Lots of literature available. Much of it is freely online. Those cycles that I showed are also freely online with some text that goes. If you put in HIV-TB malnutrition interaction in children, you will get several things. Probably not compiled the way I've condensed them together, but there is a lot that you can be able to find. But I will also be happy to share in case you want some more.
Thank you, Professor. From the online team, Dr. Sabrina, there is a question for you. How tolerable is the community pharmacy and any other community-based models to the adolescents? Professor Msime, you have quite a number of questions. Please stay with us. The first is, what is refeeding syndrome and how can we mitigate it? What is the exact recommended period to initiate ART in a malnourished child that is newly diagnosed and in need of therapeutic feeds? And the third one for you is, have you explored any teratogenic effects during pregnancy in Uganda? Dr. Sabrina? Thank you.
Mine is very easy to respond to, and my quick response would be that you look at the individual. Are they comfortable going to this community pharmacist? Do they understand that going to a community pharmacist does not negate their role in coming back to the primary care facility to, 1, be tested, 2, be counseled in a routine manner? So that's what I can respond for now. Thank you.
Thank you.
Yeah, thank you very much. On refeeding syndrome, let me stand up so that I can explain it well.
He's a lecturer at Makerere College of Health Sciences.
So that I'll not give the biochemical definition. I'll try it. When somebody is malnourished, let's start from where it starts. Your body, especially if you are malnourished for a long time, the body adjusts. You know the way body is created, we have self-correction mechanisms within ourselves. So the body gets used to having low calories in the body around because you are starving, you're not feeding well. So the body gets used to being given very little food. So it adjusts the metabolism. So the metabolism of the body slows down. So your organs use less energy than they ordinarily use. So that's a starvation state. Now, if you go to a malnutrition unit and they give you now high calorie diet, you need to introduce it slowly.
Because if you give very high calories, the body will transition from having very low calories to very high calories. One of the things that is produced is what we call insulin. You know about insulin. The diabetics lack it and it's injected into them. You get the point, eh? So now there will be a lot of release of, with these calories, there will be a lot of insulin released and lots of other biochemical things, which will lead now to pushing some of the ions there into the cells and lots of other things. So that state that causes that disorganization of the body's state is what they call the feeding syndrome. It manifests in several ways. The patient actually becomes more sick if you give them a lot of calories. They get, because of they can get a lot of fluid retention, they can get lots of other things, and actually they can even get their heart failing because a lot of fluid is not being released. And remember, the heart muscle is malnourished, so it can't pump out the blood at a very high level with all this level of fluid that is retained. So you get heart failure. So because of that's one of the manifestations that could happen. So the feeding syndrome can lead to children dying just because you've given them a lot of calories. So whenever they come, if you remember, those of you who have been to Mwanamjimu, who have been whatever, they are the formula that we give to the children. One of them is called F75. Who remembers that thing called F75? Nobody. Inid, you remember it at least. Okay, Kanyike, you don't remember? You remember? So that one is a low-calorie diet. Now, the next one, that's the one we start with, just for maintenance. It's not for gaining weight. It's just to keep you your usual requirements of what? Of the nutrients. But when you're now stable, we step it up so that you're able to gain weight. So we give you another formula called F100, which has more calories. So the transition that somebody asked about, that is the refeeding syndrome. Now asked, when do you start ART? At the point when you have moved from F75 and the patient is able to tolerate F100 or RUTF, the plumpinat, when somebody is able to tolerate that, that's a good time to start ART. So in Mwanamjimu, they have finished a period which, you know, when you're managing a malnourished child, you go from stabilizing them, then you transition them, then you rehabilitate them. In it, I'm sure you remember. So those ones are in the stage of transition. Now they are stable, they are beginning to gain weight. That's a good time. And usually the period of stabilization takes about 3 days to a week. So in the second week is good time to start ART. Once they have been admitted, you have stabilized those sort of things. That's the same period when you're also ruling out the co-infections. TB, you're controlling the diarrheas, the pneumonias are being controlled. So that's a very good time, usually in the second week. And then there was a question on, what was the third one on?
Have there been any
teratogenicity.
studies on teratogenic
Yes.
effects?
On ART in general?
DTG.
DTG. You remember
in Uganda. In Uganda, yes, there are ongoing studies. You've heard about dolphin and other things that do studies that are monitoring pregnancy outcomes, but also teratogenicity is one of the things that is looked at. And so far what it shows is that DTG is not causing any effects that are more than what is in the general population. So DTG is safe for the newborn babies. It doesn't cause them any abnormal events, doesn't lead to, for example, there were early signs in the olden days about neurotube concerns, but these were with more data, this was shown that it wasn't attributable to DTG. So yeah, there have been studies. Thank you, Professor. Back to the physical team. Any questions for? Your name?
Yes. Thank you. My name is Dr. Francis Kanyike. Thank you, Prof. Thank you, Dr. Sabrina. By the way, Dr. Sabrina taught me most of the things I know about pediatric HIV. But my question goes to you, Prof. I was comparing with the adult population. what are some of the factors contributing to the low values in the 95 ambitions? I mean, are there any hanging fruits that we can deal with quickly? Parents trust us with their children, we test them. And then where does the trust go? Why aren't they on treatment? And those on treatment, of course, you've talked about resistance and the rest, but why aren't we suppressing? Some of us who are still in clinical care, there are some of the things that can deal with quickly before the policy makers. Thank you.
Thank you very much. Very good question.
Thank you, Dr. Francis.
Hey, I wait for another one.
Yes, please. Next question for Professor or Dr. Sabrina. Oh, you're lucky. Okay. Professor, let me give you your next 3 questions. Is there any trial in Uganda aimed at understanding DTG resistance? Okay. Thirdly, what do you think have been the causes of the mutations resulting from, this time not to, but from DTG resistance? The last question goes to the 2 of you. It's not a question, actually, it's a request. Can we please have the slides?
Yeah, you'll have them.
Thank you.
Okay, the last one is very easy. You can have them. Usually the people share the slides, you can have them. Use them as freely as you want, as long as you acknowledge.
Thank you.
Okay, so the other one was, Dr. Kanyike was asking, why aren't we getting to 95 for children? There are many factors at each of those testing, the continuum of care, from testing to treatment to viral suppression and everything. There are challenges at every step. At testing level, the mothers, sometimes because you see, the child cannot bring themselves. They depend on someone. So sometimes not all the carers are motivated to bring the children. Some of the mothers do a lot to try and bring their children, but sometimes they fear the unknown. They were more comfortable to say, I'm hoping the child is negative, and they don't want to be told that actually this child is positive, so there is that hesitancy, and they wait until there is a sign or a symptom or something, which suggests that maybe they're infected. But also multiple things in the communities and everywhere that prevent the families, because some of them are in extended families where somebody is not really looking out or that kind of thing. They change carers. That becomes a bit of a challenge. Then with treatment, sometimes the formulation, you used to have formulation challenges. Many of the formulations are adult-based, and pediatric formulations take long. Now there is an improvement in pediatric formulation. Actually, the treatment gains, that the coverage that is improving is because we are having more and more pediatric formulation. Just imagine dividing adult darunavir, into, how do you divide it into pieces that a child can take? So treatment is also, formulation challenges have made the main challenge. Then with viral suppression, the children, the very young ones, tend to have very high viral loads, very high, so that when you're starting off, children, when they're starting off, most of them, if they're naive, they have millions of copies per mil. So suppressing it to undetectable levels takes a little longer. And yet they require great adherence. They depend on somebody else for their own treatment. Some are not disclosed to. So all those factors affect the viral suppression. So as we keep addressing them, and for adolescents, Dr. Chitaka has talked about several interventions that can be used for the adolescent, but some of them are also applicable to the younger children. That engagement to ensure adherence. Then the DTG resistance, and there are multiple studies. Most of the trials that are using DTG are also doing resistance testing as part of the studies. Many cohort studies, like the one you've seen from Malawi, are also documenting the resistance mutations. And then somebody says, what causes resistance? Resistance to DTG is the same like for all the other ART. The way resistance develops is when you give a drug at suboptimal levels. The amount of drug is not enough to suppress the virus, and the virus continues to multiply in the presence of that low level of drug. That's what causes resistance. So if you are not adhering properly, but let's say you take one tablet today, then you skip tomorrow, you take the other day, that suboptimal resistance. So the virus continues to multiply because with the load, no drug. So for example, if somebody does not adhere at all, they will fail. They may even progress to advanced HIV, but they will not develop resistance because there is no drug. But if they are adhering fully, still they don't develop resistance because they are fully suppressed. There is no virus. But that mid-level adherence is what really causes resistance, where you take and skip, skip, that kind of thing. That is what really leads to resistance, because the virus continues to multiply in the presence of drug.
Thank you, Professor.
So the same thing happens to DTG. So for all ART, that's what happens.
Thank you, thank you, thank you. As you all know, as of today, our two wonderful speakers are lecturers, and I am a by proxy lecturer at this moment in time, so I'm standing this side. And before I officially close, I am just going to have 8 questions to confirm that we've done it well. Not so? The sooner we close this, the faster the certificates will come through. What is 95, 95, 95? Our two speakers are both listening. Oh, thank you very much. Those that have not spoken, what is 95, 95, 95? Brenda?
The first 95 means that the people that are living with HIV, at least 95 of them have been tested. Then 95 of them are actually on ART, and then 95 are suppressed.
Professor, are you happy with that response? She says 95% tested. No, they are tested. 95 have been initiated, and 95 are virally suppressed. He's happy. Thank you. When do we initiate ART? Recommended time of initiation of ART in those children that have both malnutrition and HIV. Quick answers. Those that have not spoken, should I randomly land somewhere? Somewhere? Oh, thank you.
My name is Martin Sachivam, a Victoria University student, nutrition student. So according to Professor Musime's explanation, let me say like they have been taken to a unit, let me say Manam Jimo. So after stabilization, after you've taken them off F75 and they are going to transition to F100 or ready to use therapeutic food, that's when you're supposed to initiate.
Professor Msime, are we happy? Good. Why are adolescents special? Any counselors in here?
Thank you very much, Doctor. My name is Margaret Mugisha, a counselor. So adolescents, a very special group of people because a lot of things are happening. They are transitioning from childhood to adulthood. So a lot is happening in their physiology, in their physiological setting, their psychological. So many things are happening. So they are a very special group of people to handle. Yeah, that's what I can say simply.
Dr. Sabrina, are you happy?
Yes, I am. She's said most of the things.
Thank you. Professor Msime made an effort to give us some statistics, and I know we are not very many statisticians in here, but he specifically mentioned malnutrition, HIV comorbidity. What is the prevalence, and what is the one of HIV malnutrition in the non-HIV population? Epidemiologists, where are you? Public health. No, the comorbidity, malnutrition and HIV. No. Adult education. Fair try. We don't say no in adult education. Who remembers? You remember something? Very good. Thank you very much. We are happy. The lecturers are happy. Yes, in those that they have sampled and registered, 9.5. Spot on. Thank you very much. More questions for you? People then begin to look at the tables. For that matter, let me close this session. Thank you very much. You've been a pleasant team to work with. Once again, thank you, Professor Msime. Thank you, Dr. Sabrina. I'm actually not a lecturer, so I'm back to my usual status. Have a good evening. See you tomorrow.
She's aspiring.
Kindly confirm. Oh, there is a cup of tea for each one of you here. Online team, I don't know, can we send you pictures of the tea or something? Thank you very much once again. Have a pleasant evening.